And then it's the management rules. Sorry. What do you mean? Hello, hello. Okay. Right, I'll just hello. Hello? Yeah, but it's not that one. Oh, we just wanted to connect it. Okay. Can you like just say some stuff in this area? Hello? Hello? There's nothing going for that, right? Not that. So this is connected to Zoom, and this is the microphone for the thing. Okay. This is just so people can hear and go, wow, I look bad today. Oh, good. How do I stop video? Okay. So, yeah. Okay, so that's all good. It's recording. Open Zoom, start video. I'll just make sure that audio is on. Tell them to mute just when you say the meeting. Okay. Yay, that's done. I have no idea what this is. Oh, I care about logging into my Facebook. I just don't know what my password is. I don't know. Oh, okay, cool. Hey, Cuddy's in. Oh, okay. Yeah, you're better than that. It turns this off though. Oh. No. Okay. What am I doing? I sent this to you. Oh, did you share it? Yeah. Okay. That's fine. I should probably get up the. That's not awesome. Okay. Do you have to do this as well? Is there an option to just like not do it? I don't think so. I think I'm okay. Oh, for fuck's sake. Okay. Oh, do you mind like when you were driving down? Like it's yeah. Okay, that's done again. Who is the speaker? Or do you? I got it. Yeah. It's got. I think hopefully everyone. Yeah, I
Like it feels like
the only feedback I got was oh what happened? They didn't make you prepare for it. No, it was there. Yeah. Well, I'm gonna fix the fonts.
yeah, you know, it's download like a
Oh,
20 fonts.
I can't believe you knew how to do that. I was so mad.
I went to music. It's so ringing.
I know, I know.
Really cool technology.
It's because there was things I was like, oh, I've given the key to Daisy. Oh, dude, don't worry, I did the same. Oh no, don't worry. It's okay, we're here.
All the animations and stuff, alright. I wasn't sure if you're like.
Cute.
Oh, cool. Oh, cool. Alright.
Yeah. Oh, there's actually. It's the Oh shit. Okay. I'll let you know in just like 10 minutes. It should be cool. Yeah, you made it. You're still on time.
I feel really uncomfortable, like how close.
I know. I do. Usually, like, we're gonna be an hour early. Yeah. And it's very Yeah. Oh, good. Sweet. Well, and then while you're speaking, just look around to this.
I don't know how, like, they are, like, asking questions.
Yeah, I listen to people you know.
Oh, let's see if I can know any voices. Please don't pick on me.
This is hello.
Oh, so slow. Oh, I thought I would see someone I know, but I didn't see anyone. Yeah. Oh, thank you. How do you know this? Yeah. Yeah, I was gonna if Joshua was here. I was literally just gonna ask him where this is. It's alright. Yeah.
I always do the thing where I like someone and then I'm like, that's the thing. So like,
Yeah, I'll do that this one.
But like,
Hello? No.
yeah, as in it'll come through Zoom. But for them, it'll be that one.
It'll be this one.
Does that work? Oh, that's muted.
Oh, okay, alright.
Oh, sorry, Jen. Switching off the nuts. That's like
Am I starting now? I should start now, right? Oh, okay.
I think
Where's Joshua? Or like Sophie lives there. Where's Sophie?
she'll hate me for this.
Where is
She's like
Sophie?
second row in the back. Like in that way. Like,
Oh, okay, I guess I can
yeah, you got
see.
three. Yeah, Sophie's just like there.
Oh, why am I struggling so
Oh, she's
hard?
like to find someone's head. She's got a map. Do you see the red iPad?
Yeah.
Yeah, next to that.
Oh, I see her. Okay. Sweet. Okay, so I've got Sophie, I've got Andrew, and then I've got, I just need Joshua.
He should be here. He should be here.
And the thing is, I've gone through this stuff with them before, so.
Oh, okay. Yeah. Yeah, exactly. They have no excuses.
Yeah, I know. And then I'll be like, why the fuck don't you know?
Yeah, exactly.
Let me down.
Yeah.
Yeah.
I just said that. Are you excited? Hannah's best was always the best.
Oh no!
I'm not kidding. No, legit. I would always come to yours. No matter what.
Did you be better? Is that why?
Yeah. But like, so some of this is kind of like really old, like scraping.
That's right.
So I'll see. I'm sure.
You should have seen me last semester. The first day, like I could not sleep. I look back now, I'm like, holy fuck, I was so stressed. And then this morning I woke up and was like, oh.
Yeah.
And then like shit happens, and I'm just like, it's fine. Yeah. Yeah, exactly.
This might project though.
Yep. Yeah.
So we'll have both. Yeah.
Yeah, so this one won't project any sound. It's just that people can hear.
So yeah. So just talking about general.
Like kind of halfway.
It'll be fine. I said there isn't like a back sound from that.
Yeah.
I will be fine.
Maybe that's what that was. Okay, no. It's
It'll
cool.
be fine. It'll be fine.
We're good. All right, we're gonna start here.
Oh, I know. That guy looks very familiar.
Oh, hey. What happened? Oh, fuck. Is it broken? Or is it okay? Okay.
The third case that I helped last was
Yeah. So you probably pick up mine.
problem is I don't remember the name.
Jenny Jack Spears. Is it or Michael Turner? He'll answer.
Oh, he's an idea. Why?
Yeah. He repeated. He cheated in the exam. He wrote. He was like. Oh wait, no, he didn't even cheat. He was like trying to memorize questions because we were all doing it, and then he wrote it on his hand. Yeah. And they saw it and they were like, mate. And even though, like, obviously he took it to explain, he's like not cheating. He's just trying to do it. I mean, it's still against the rules, but they're like, sorry, you're gonna have to repeat it.
If I was like, I'd be so disappointed. I was like, I'm like,
I know. Imagine your mom hearing that's why you had to repeat an entire medicine. Okay. Good morning. Good morning. All right. Thank you guys for all coming down again. We're just waiting for a few more people. Awesome. So thank you for coming down on your weekend. For everyone who came to Muppets yesterday, I hope you had a good time. It looked awesome. So today we'll be going through women's health, and I want everyone to welcome Hannah, who's going to be going through everything to do with menstruation and period problems.
Hi, I'm Hannah. Nice to meet you all. So yeah, as she said, this morning we're going through some period problems. So we'll be starting off just going through some basic physiology of the menstrual cycle, contraceptive methods that are available, and then some disorders of the menstrual cycle. Hopefully I stay on time. See how we go. And I don't know how interactive you are as a group, but if you don't answer, I will pick people. So, okay. So starting with menstrual cycle. I know you guys probably aren't super interested, but I do recommend going through a little bit of embryology and kind of like oogenesis. It does really help you to understand sort of everything else in women's. We don't have time, obviously, to go through all of that, but do any of you know a little bit about, like, you know, we have all these follicles in our ovaries, like when are these kind of all made in the woman? Sorry? Yeah, in the fetus. So every single follicle that we will ever have in a whole lifetime is made in utero. At about 6 months is when you have your peak number of about 7 million follicles. And then over then, it's just, since then, it's like downhill. They just slowly undergo atresia until you run out. And do you guys know a little bit about, so there's an interesting thing that happens with the follicles, because you don't just start having periods as soon as you're born, right? So what is it that happens to the follicles? Why is it that you don't have periods until menarche? So it's because if you remember in oogenesis, your cells go through 2 phases of meiosis. So what happens is, interestingly, in fetus, as in utero, your follicles get arrested in a phase of metaphase, of meiosis 1, and they stay like that until you reach menarche, where special things happen, and then it triggers them to actually start continuing through meiosis. But unfortunately, they continue to go through atresia. And so by birth, you've already lost like 3 million follicles. When does menarche happen? Huh?
When you get post-child generation, something or other.
Yeah, oh, you jumped a step. So I meant like an age. Yeah, pretty much. There's like a bit of a range. Seems to be getting younger and younger. But basically, once you hit menarche, then, you know, as he mentioned, you start getting these changes in your GnRH pulsations, and then you start recruiting these follicles every month, of which only one is supposed to ovulate. Cool. So we'll go into a bit of then how does the cycle actually work. And we've mentioned the GnRH pulsations. What are the 2 kind of physiological stages that your menstrual cycle can be divided into? Yeah, follicular and luteal. And which of the 2 are usually the fixed? It's like fixed number of days. Yeah, luteal. So luteal is usually 14 days, and follicular is the one that can vary. Normal cycle, as you guys would know, is about 28 days, so it can be longer, up to like 35 days, and that's perfectly normal. I guess, so you start having these GnRH pulsations that trigger you to start releasing FSH. And what does this all do? What does that mean? What does FSH actually do to your ovaries? Yeah, to mature. So as I mentioned before, you start recruiting these follicles and they start to grow, and then what happens? Anti-Mullerian hormone. What's the main hormone in women? Estrogen. So yeah, so as the follicles start growing, the kind of cells that surround them start to mature and change, and then they progressively produce more estrogen. And how is it then that we end up having one mature follicle? rather than like 10.
The one that is becoming mature starts producing vision and that has negative feedback and stops FSH, the other one.
Yeah. So that's one part of it, and there are some other aspects of it too. So it's thought that estrogen also itself has a negative feedback effect on FSH release. The theory is that, like, alongside that, the one follicle seems to have kind of different FSH receptors or particularly sensitive ones. So even though the FSH content is going down, it still picks that up and continues to grow and continues to produce more estrogen, whilst the others that were recruited kind of die off. So then you end up with one dominant follicle. And then, so you have this follicle that's growing. You're reaching this ovulation. What is it that happens that triggers ovulation? It's LH surge. You get an LH surge that basically it pushes, it does a final maturation of your follicle. The egg sort of gets pushed one side and then it ovulates. And obviously then it travels through with the goal of, if you were trying to become pregnant, meeting the sperm. And what's left behind from where it ovulated? Corpus luteum, yeah. And what's the importance of the corpus luteum? Yeah. So because the progesterone end produces a bit of estrogen as well, that helps maintain the lining until, if you were getting pregnant, the blastocyst would implant, form a chorion that would release then HCG that would maintain the production of estrogen and progesterone, and then you don't need your corpus luteum anymore. But in the absence of a pregnancy, your corpus luteum eventually degenerates, you run out of progesterone and estrogen, and so then your lining isn't maintained anymore, and then you kind of shed all of that, and that's your period. So that's the menstrual cycle. I'm sure you guys know that very well by now. So if you don't want to, obviously, you don't want to be pregnant all the time. So there are some contraceptive methods out there. A classic station that you might get on your OSCE is something like, there's Gretchen. She comes in because she wants to start the pill. So depending on the station, you may or may not need to take a history. It varies. If you do, it'll be super, super, super focused, just like purely past sexual history, do you use contraceptives, have you had STIs before, etc., etc. But sometimes it will be just like a pure counseling station, like a very GP-esque station. And it might not necessarily be the pill. It might be that you need to also counsel on alternative forms of contraception. So say this is your OSCE station, and say you've already been like, oh, what do you know about the pill? Oh, how do you feel about it, etc., etc. What are some of the things what's the first thing you'd want to talk about with this patient? Indications, yeah. So what are some of the indications for the pill? Contraception is one of them, obviously. Sorry? Yeah, so you can help stabilize very irregular periods and heavy periods as well, or painful periods. Anything else? Sorry, I didn't catch that. Oh, yeah, PCOS. And like acne and stuff like that. And then you might want to talk a little bit about perhaps some contraindications. Do you contraindications. Yeah. So do you guys have any like absolute contraindications? Yep. Past history of like stroke, DVTs. Yep. Yep. Severe migraines. Sorry? Anything else? Oh, yeah, so if you're over 35 and you smoke more than 15 cigarettes, that's a no-no. Yeah, that's pretty good. And then you might want to talk about then a little bit about like what the pill actually is and how it works. Yeah. Whatever. So yeah, how does the pill work? So okay, so the pill, I'm sure you guys know. It's it contains estrogen and progesterone. Different formulations exist out there, but the idea is that kind of shuts off your FSH, LH production, so it prevents you from ovulating. Or when you're saying to a patient, you shouldn't say that. You should say it puts your ovaries to sleep, so that you don't make eggs anymore and you won't get pregnant. There are some formulations out there that I do recommend you knowing. Do you guys know of any particular brands and like? much the same thing as endometriosis. The only downside is that it's harder to diagnose because you can't really visualize the lesions. So, you know, I think on ultrasound, sometimes you can see kind of like hyperechoic lesions in the uterine wall, but obviously on hysteroscopy or on laparoscopy, like, you're not really going to see them. So it's kind of based on your history, having other negative investigation findings, plus your imaging, etc., that all put together leads you to think it's probably adenomyosis. And then management is going to be very much the same. It's going to be the pill, NSAIDs, etc. Not a lot we can do for them, unfortunately. So yeah, and these are just some of the other potential questions or stations that I thought would come up on your exams. So most of it's going to be history and then management / counseling. It's possible that you will get an explanation station of a particular procedure, so something like a hysteroscopy, DNC, or maybe like a laparoscopy. So I do recommend kind of knowing a little bit about how they work pre-op, during the op, post-op, etc. Fertility, someone else is going to come and talk about that. I think we've got a little bit on. Oh no, we finished. Yeah, it's 9:45, right? Okay. Yeah, okay. So yeah, so that's it. That was it. I was gonna do this if we had time, but forget about it. Yeah. So that's it. Okay, thanks guys. Okay.
This would be fun.
Yeah, I was like, I really hope they get the reference because.
Oh no, thanks, Han.
No worries.
Well done. Wish I had this too. Maybe we can. Nah. I was like, we can go through it during. Nah. I don't know if it would. Are you fucking serious? It's right there. Oh, you got the actual. It's all good. It's good. You were still. All right, guys. Thanks so much, Hannah. Next, we've got Sabrina, and she's going to be going through infertility, gynae cancers, and procedures that you should know. Please welcome Sabrina.
Hi guys. First of all, thanks so much for coming out today on such a cold, early Sunday morning. It's really good to see so many people, and it's a bit intimidating. But what I have today is basically an overview of infertility, gynae cancers, and procedures. I sort of merged the procedures in with the gynae cancers since lots of them overlap. Also, Hannah's gone through a few topics which I'll be going through as well, so I might whiz through some slides there as well. But if you have any questions anytime, just shout out. So just some general tips and tricks, which I have. I found that, particularly with women, going through your past paper options is really valuable, especially when all the options can be so specific. I think having just a one-liner, one sentence about every single possible condition or any treatment that comes up I think that's something it's worth spending some time on. And also approaching each topic like an OSCE. So if you can actually explain it to someone and go through your general structure of definition, etiology, pathophysiology, signs and symptoms, how do you treat it, and general management. I think that's a really good way to sort of structure things in your head as to how to present things when they come up, whether it's in your written exams or also your OSCEs. And just having a rule of three, so just having like three top diagnoses, three top differentials for any presenting condition, three top signs and symptoms or buzzwords, essentially. So that's really helpful. And also go for the big picture as well. It's best to spend time learning a bit of everything as opposed to really specific stuff about certain areas. So that's just my general advice. Alrighty, so moving through infertility first off. So infertility, what's your definition for infertility, primary or secondary? Anyone? Yep, and what about primary or secondary infertility? Yeah, so primary is you haven't been pregnant before, and secondary is you've been pregnant before. So that could be a new partner issue, could be a new issue in yourself. Very much like your amenorrheas. Great. And it's a really common issue nowadays, especially with aging couples. So it happens in 1 in 7 couples. And but with fertility, up to 90% of couples can conceive after 3 years of regular unprotected intercourse. So a lot of IVFs now are being rushed. In the sense that people don't want to wait as women are getting older and they worry about their egg quality. So waiting is always an option which you can counsel patients on, depending on the female's age and what they want. Okay, cool. So in terms of etiologies, 20% is roughly male causes, 20% is roughly unknown, and then 60% is roughly female. And just going through the causes of conception, your irreversible ones are definitely your egg qualities. So after age 35, your quality and your quantity of your eggs start dropping. So that's something which you can't change in yourself. But there are several reversible ones which you can, and that's what you can counsel patients on. So that's your smoking. So smoking reduces your fertility by up to 2/3 for both males and females. So it can block your spermatogenesis, can reduce testicular size, can also change your cervical mucus motion. So that can also affect how your egg travels down the fallopian tubes. So that's the first one. So coital frequency is also another one. Libido. So when you're counseling patients, in a sensitive manner, ask them like how often are they having unprotected intercourse. So it should be 2 to 3 times a week, ideally. So in terms of alcohol, that can also affect your conception rate. So your testosterone production can be impacted, and also like impotence and also ovulatory dysfunction. All of that ties in with alcohol and drug usage. Body weight's a big one as well. So if you're overweight or underweight, so BMI less than 19 or more than 29, all of that can affect your ability to conceive, especially for females. So some drugs as well can impact your fertility. Do you guys know some drugs they can shout out? Yeah, antipsychotics definitely can. So especially second generation ones with the metabolic syndromes and everything. Great. Chemotherapy, yeah. So that affects your fast multiplying cells. Yeah. What about some rheumatoid drugs? And methotrexate as well. So you definitely don't want to get pregnant if you're on methotrexate. So generally, if you're on methotrexate, you want to give them, say, 6 months at least of not getting pregnant. Okay. Some other ones which I have is actually NSAIDs. NSAIDs can inhibit ovulation. Chemotherapy, as we mentioned before, it breaks down your rapidly dividing cells. Also, your cimetidine, so it's an H2 agonist for your stomach, and that can also affect your prolactin levels. That can also affect your HPA axis. Also sulfasalazine, so your DMARDs as well. So if the patient has any rheumatoid conditions, you want to ask about any other drugs they might be on. And also obviously your androgen drugs as well, so any steroids. Cool. Occupational hazards as well, so any chemicals or radiation, you want to touch on that as well. Cool. So going through infertility, you can basically break it down into your central system, which is your brain and your pituitary, and you can also break it down to your reproductive system. So problems with like the testes, the ducts, the tubes, problems with the ovaries, the uterus, the fallopian tubes, and vaginal implantation. There's two ways you can break it down. So in terms of your hypothalamic and your pituitary causes, they're seen more as like central causes of infertility. And if you have problems about any problems up there, how would you voice that? Because it's one thing knowing that that can be an issue, but it's another way of like trying to get that across in an OSCE station and actually getting it in explainable English. So how would you ask them if they might have troubles with their pituitary or with their hypothalamus? Yeah. Yep, so changes in vision, that's a good one. Yeah. Yeah. Yep. So, for example, yeah, so what's a symptom of prolactinoma that you might find more so in male than female, maybe? Yeah, okay. So galactorrhea. So if you have high prolactin, that can lead to galactorrhea. So you can ask if you've noticed any milk from the breast, so things like that. Great. Another big picture thing which I was sort of hinting at was like if you have anorexia or any body mass BMI issues, that can also affect your central nervous system and your central causes of fertility. So going through hypothalamus, like your weight extremes, so you want to ask, what is your BMI? Do you know what your BMI is? Again, your patient might not actually reflect the age or the BMI of your patient in the STEM, so always ask that. Have you been doing any heavy exercise? They do, their occupation is really important. If you're like a jockey or like an endurance athlete, people do dancing, stuff like that. You want to ask about if they've done heavy exercise, any stress as well. In terms of pituitary, as we mentioned before, your prolactinomas, you can ask questions about whether they've noticed any milk leakage, a pituitary adenoma, as you're saying before, Jake, so like your vision problems. So Sheehan syndrome, do you guys know what that is? Yeah. What's Sheehan syndrome? Yeah. Yeah, awesome. Okay, cool. So postpartum hemorrhage leading to like avascular necrosis and ischemia to your pituitary. So this is like a secondary cause of infertility. And you can definitely, what can you ask? How can you ask if you had Sheehan syndrome before? Pardon? Yeah, so that's a lead on. You can also ask if you had PPH in the past as well. So severe PPH. Nice. Cool. So then starting to go down to your central reproductive area, your ovary, what sort of questions might you ask about any ovary problems or anovulatory problems? Yeah, good. What else do you want to ask? Yeah. Yeah, good, good. Those are all really good questions to ask as a baseline for any obs or gynae station. Nice. So just stuff like simple anovulation as well. The cycles, any signs of PCOS, so like the hirsutism, acne, BMR, etc. POF, so premature ovarian failure. So you can ask if their cycles have changed recently, any family history of POF, since that's quite a large part of family history. And also any congenital ones. So what congenital syndromes do we want to ask about? So we mentioned Turner's in the last talk. Any other ones? So Fragile X. Fragile X is another one where they appear like female, but they've got ovulatory problems as well. And also whether they had periods yet or any amenorrhea. And also endometriosis questions. So if you ask about tube problems, what sort of things do you want to ask there? Yeah, PID, have they, yeah. Have they had any STIs in the past, any STI screenings up to date, partners, etc., etc.? What about the uterus itself? Yeah, any heavy bleeding, any menorrhagia, good. Any painful periods, any dyspareunia. You can also ask if there's any polyps can also affect fertility as well, so you can ask about any intermenstrual bleeding as well. Cool. Cool. All right. And also thyroid as well, so that's sort of separate to your whole HPG axis. So what questions will you ask about for the thyroid? Yeah. Yeah. Cool. So hyper and hypo can both affect your ovulation and everything. Great. Cool. This is just a quick table showing a summary of questions that you might want to ask and also examinations. You can read through that in your own time. But just going through infertility for male causes, because the male causes are slightly smaller than the female ones, it's good to go through them first. So in terms of your male causes, generally, what 2 tests would you guys do for male infertility? They can just rattle off in an exam. Yeah, nice, cool. So essentially, you're right. But going through your causes as well, how would you break down your male infertility causes? So you've got your pre-testicular, your testicular, and post-testicular. So pre-testicular could just be problems with your axis, as mentioned before. It can be tumors, so any testicular tumors, any ischemia, so if you had testicular torsion in the past that hasn't been fixed. So going on to testicular now, so things like Klinefelter syndrome can also affect your fertility, drugs, radiation, infections, trauma, varicoceles like mastectomy, cryptorchidism, so that's more a pediatric thing when you actually try and feel for testes in your newborn exams. Mumps in the past, that can also affect orchitis, that can also affect your fertility, and age as well. Moving on to post-testicular causes, CF can definitely affect your ability to have effective sperm, given that your vas deferens is not normal. Infections, surgical procedures, trauma, and erectile dysfunction. All questions that you want to cover in your history. Cool. So with our male investigation, as you mentioned before, semen analysis and anti-sperm antibodies are things that you can just rattle off really quickly. There's just 4 terms which you sort of need to know, which is azoospermia, which means lack of sperms. Oligospermia is like reduced amount of sperm. Asthenospermia, which means a decreased motility in sperm. Then your teratospermia, which is like your abnormal shape of sperm. Yeah, so these are just terms which are good to know. So terato also ties back to teratogen, so just abnormal looking. Cool. So just a quick question. So what do you guys think?
Oh no, this is from my USB, right?
Yeah.
Oh, this is the right.
Yeah, every time I see that, I'm like, it's just, what is it? It's
All right, thanks guys. We might get started for the next one. We've got Sameer who's going to go through everything pregnancy related and antenatal care. Please welcome Sameer.
We're running a bit late, so we're going to go through this quickly, but we're going to go through quickly anyway. So this doesn't, Jen, the keyboard doesn't work. Jen? Oh, okay, it does work. Okay. So we're going to start off looking at preconceptual history and advice and what actually happens over the 9 months in which someone's pregnant. We'll cover briefly some of the gestational medical disorders, but I've added a lot of that at the end. You haven't got it in your slides yet. I'll upload a new version, just a lot of the acute liver stuff of pregnancy and a lot of those evil diseases that people don't like teaching you guys about. So we'll start off really quickly with what happens before you're pregnant. So someone comes in, they tell you, I'm thinking of getting pregnant, and you have to take a generic gynae history. There's nothing in particular that you need to look for that you wouldn't do otherwise. It's worth noting that things like can I close that door? It's worth, the echoes are weird. It's worth noting that things like menorrhagia and dysmenorrhea might be indicative of things like a bicornuate uterus or other cervical pathology that might make it harder for someone to become pregnant. But typically you won't be super investigating them until they've done all the stuff that Sabrina recommended before, lost weight, having lots of sex, before you start investigating these further with investigations. An obstetric history, if applicable, is something you must do. In particular, you want to know about what actually happened to their previous pregnancies and each pregnancy in quite a little depth. Each G, you want to see whether it became a P, and you want to know about the outcomes, what actually happened in terms of the baby's course after it was born as well. And a normal medical history is obviously required. The one thing that you may not have covered in too much depth is type of care and the goals of care. So people can be managed by a midwife, people can be managed by a doula, not too common, thankfully. People can be managed by a midwife, they can be managed by a GP or an obstetrician. Most people will slip in between all of those streams of care as requiring as to the positive investigation results they have. But it's worth flagging whether or not the potentially pregnant woman's like some kooky person who only wants to see a doula, because you want to disabuse them of that notion quite quickly. So while someone isn't pregnant, it's much easier to stop lots of bad things from happening. You don't want them to smoke, you don't want them to drink, you want them to have good control of diabetes. If they're on any dodgy medications, a lot of your anti-epileptics and some of your anti-migraine and hypertension meds in particular, if they're anorexic, they won't be able to become pregnant, and you'll want to stop them from having an early fetal death. You want to test for varicella and immunize, avoid listeriosis and toxoplasmosis, which is lots of really nice foods. And obviously you want to stop them from doing recreational drugs. So smoking has a wide raft of side effects. I think this is mainly taken from Weston's OSCE book. So you want to look at it kind of in a really structured way. So what happens before or even at the time of conception? It's harder for you to conceive. Things like ART are more likely to fail. You're more likely to go through menopause early. While you're pregnant, you're more likely to have a fuck up. So spontaneous miscarriage, abruption, premature ROM as well, previa, low birth weight, and having a small infant are much more common if you're smoking. The vast majority of that is done either by nicotine's direct effects on the rest of the body in terms of being a hypertensive agent, or that there's an actual vascular damage that occurs the same way you get peripheral vascular disease of the legs, where your placenta is less able to perfuse the baby well. Postnatally, so even if the baby survives your deliberate attempt to harm them via smoking, they're at high risks of brain tumors, respiratory illness, and SIDS. And that's even if the husband is smoking or anyone in the house is smoking. And there's an overall perinatal mortality risk that they haven't really etched out every single reason for, but we know these babies are more likely to die before the age of 5. In your treatment of these ladies, you pretty much just recommend the whole family needs to quit. It's a family approach. You're about to have a family. Quick groups are great. We don't recommend a lot of the drugs like bupropion. That can often be embryotoxic, but things like Champix, which I think is varenicline, is still appropriate. And while it's hard for them to stop smoking cold turkey, they can do it and they can do it safely. It won't kill them. It'll just be vastly unpleasant. The other big one to avoid is alcohol. So this is a picture of a girl with fetal alcohol syndrome. We don't know much about this syndrome. We don't know what the safe levels are. Realistically, if you saw this person on the street, you wouldn't pick them as obviously syndromic. But there's no known safe level of alcohol. Fetal alcohol syndrome involves a vast of congenital cardiac, gut, and cognitive issues. Some of those are mentioned there. And the treatment, basically, if someone's an alcoholic and wants to become pregnant, is they stop drinking, but they can't do it cold turkey. Because if you're an actual chronic alcoholic and you go cold turkey, you'll get delirium tremens. And while cold turkey smoking won't kill you, delirium tremens can actually kill you. So you'll have to go through all the stuff you've done in third year probably about, are you a chronic alcoholic, and the cage questions and all that sort of nonsense. So poor diabetes control, I think I'll cover this later. It's at the very end of the slides. We probably won't get to it. But there's lots of fetal abnormalities. Most of them are just things like macrosomia, but there's some really nasty ones that happen to type 1 diabetics in particular. So things like a sacral dysgenesis, for example, spinal tube defects are more common if you're a type 1. You fix their glucose, you refer to everyone you can think of a diabetic needing, a podiatrist, ophthalmologist, a kidney specialist, a natural endocrinologist. Do all of your referrals. And at this point, it's probably worth telling them, if you do become pregnant and you have high glucose, this is what your life will like. And you list out all the risks all the way up to birth, where if they have a Caesar, their wound's not going to heal. If they don't have a Caesar, there's a high chance of things like postpartum hemorrhage because of a macrosomic infant. But we'll get there later. These are some sort of buzzwordy stuff for recreational drugs. You can come back and look at these later. I would pretty much just think of it as it's your uppers that cause more of the bigger problems. As you can imagine, your uppers increase your sympathetic tone, catecholaminergic surge leads to things like hypertension. Hypertension leads to things like placental abruption. Your fetal death in utero often happen because the hypertension means the blood's moving too quickly through the placenta for actual effective perfusion, and that often causes harm in and of itself. Opiates is the other weird one. If you've done psych, you've probably met people whose babies are on NAS or on the neonatal abstinence syndrome. So babies get used to taking heroin. When they're not on heroin, they obviously have a sympathetic response, and that's won't kill them, but it's very uncomfortable for the baby. So people will tell you that motherhood is this mystical, magical thing that changes who you are and the rest of you can't accept it. But we do understand what happens to their body. So this is a summary slide. I've highlighted what's important. So when someone says, you don't know what I've gone through, you can tell them about the increase in their cardiac output by about 40%, and how if they lay flat, they're going to compress their inferior vena cava. You guys can't see that. Yeah, anyway, so that's supine hypotension. So you lie in a left lateral position. The other important ones, if you do a vital check on someone who's pregnant, especially if they're kind of getting late pregnant, they're going to be breathing quite quickly. And that's actually normal, but you want to make sure that they haven't tipped into pulmonary edema, which can happen even in the absence of previously known heart failure. So things like I think they call it natal cardiomyopathy are unfortunately not completely uncommon. These patients are in a hypercoagulable state, and the reason they do that, the body's done that to prevent postpartum hemorrhage, because evolutionary, we didn't have a bunch of awesome drugs to stop that. These patients will normally have a glycosuria, so you always do a urine test on someone who's pregnant, and the main reason you do it's not for glycosuria. Yeah, sure, if they're really, really high in glucose, you might be worried they're becoming diabetic. But the main reason is actually for preeclampsia, which I think Joel will talk about a little bit later in the next slide. So it's from the endocrine stuff. Increased beta HCG and HCG in general is associated with a couple of conditions we'll discuss briefly. Increased progesterone causes smooth muscle relaxation. So lots of those common nasty complaints people talk about, reflux, problems with urination, are caused by smooth muscle dysfunction. The last one that's worth knowing is there's lactotroph hyperplasia. That's reasonable. It happens so that the women can effectively breastfeed, but the hyperplasia occurs at a rate faster than the growth of collateral vessels. So when they do have a blood loss, often from postpartum hemorrhage, they're at risk of Sheehan syndrome, which is pituitary infarct secondary to postpartum hemorrhage or other blood loss at the end of pregnancy. Sheehan syndrome is something that could reasonably come up in one of your EMQs. So when someone is pregnant, so they've tried to fix their life, how much they've succeeded, and they say they are actually pregnant, you want to do a couple of things. So these are the 9 things I like to do. I want to start off with dating. I want to find out, when were they pregnant? What do we expect the time of their delivery to be? And that's quite important for women in terms of organizing the social supports that they'd like to have present and that sort of thing. You want to find out if they're on any actual contraceptives. Things like intrauterine devices in particular need to be removed. And especially if this is a GP, like if your OSCE says you are a GP, often you might want to refer them to someone to remove those rather than you doing it yourself, because you could cause a lot of damage. If they've had pap smears recently, they can't have one now because it's 5 years. But if you're due, you're going to give them one. You want to know about their previous gravidity and parity. So you want to know there's a bit of detail, which we'll cover in a moment. Current minor symptoms, social aspects of pregnancy in terms of who's going to raise the baby. Are you in a recent, decent financial state? Breastfeeding, past medical history, and a social history. So dating, ultrasound is the best way. People are awful at remembering the time they became pregnant and awful at doing numbers in general. And many women don't work in terms of the normal cycle lengths and the calculations of Nagel's law that some people still use. But we want to know if they're regular, and we want to know about how long their cycle is, and then you can kind of have a decent guess. So gravity and parity, you want to know whether the G became a P, and if it didn't, why not? Many women won't have a diagnosis, as someone may talk to you later about. Most of the time when there's an antepartum bleed that results in loss of pregnancy, we don't have a diagnosis. Things like aneuploidy are probably a common cause, but you want to know if they've got a diagnosis, why they're not able to actually become parous. Each actual Paris baby, you want to know if it's a still or live birth, how they were delivered, in particular if they had a C-section, what type of C-section, what type of C-section they've had, how long the pregnancy lasted, any complications, and who looked after mum after the baby was born and who looked after the baby after the baby's born. Most women also know the weight of their kid. It's not particularly useful unless the kid's extremely small or extremely big. So there are lots of current minor symptoms of pregnancy and like sort of small complications. A lot of these are progesterone mediated, as I flagged before. Things like urinary frequency, breast tenderness. Other things include fatigue, nausea, a pelvic pressure, especially if they're coming to you a bit late, like somewhere around after the 12-week mark. They might be worried that this is someone who's a lot more pregnant than they thought they were. These women often have trouble sleeping, which is probably a dopamine-mediated response. And a lot of women will have pervaginal bleeding. So a third of women have it. Most of the time, it's not a bad thing to happen. It just kind of sucks. The management, if it's not a bad thing, is they rest. People often forget, chill out a little bit, don't do anything silly, don't exert yourself. But rest is probably not evidentially based to stop any risk of future APHs. So nausea and vomiting in pregnancy is really common. Morning sickness is less common. Morning sickness only happens in about 2% of the patients who experience nausea and vomiting throughout their pregnancy. But morning sickness will work in an OSCE if you ask them, have you had morning sickness? The management's really simple. It's small meals, dry carbs, low fat, and you'll often want to give these people thiamine. Some of your food has thiamine in it, things like beef and liver and dried milk, but like this is a bit weird. Just give them thiamine tablets and they won't have to change their life while they're pregnant. It's much easier. But some people get really, really bad nausea and vomiting. So a really brief chat about hyperemesis. So there's probably lots of different causes. So it's associated with increased beta HCG, which is associated with molar pregnancies. It's also associated with a female embryo, as well as if you have a Helicobacter pylori infection. It's probably to do with somewhat your increased thyroxine because your beta HCG chain and your thyroid hormone are similar physiologically. You're absolutely stressed because you're pregnant and there's a mechanical obstruction. You've literally got a big mass growing in you. Masses are bad. And because you've got a mass, your body responds by increasing activation of the chemotaxic zone. So the definition is that you have to have excessive nausea and vomiting. That means you can't eat and drink. It's very much a clinical definition. You don't need to have things like urinary ketosis, but you need to just look at them and say, I don't think that you're doing well. Typically, they'll be losing more than 5% of their weight. They'll be dehydrated. If they've got a diagnosable nutrition deficiency, if they're acutely Wernicke and cephalopathic in front of you, that's a bad sign. But otherwise, you'll note it on things like urinary tests. Typically goes away by the end of the first trimester. And some of the ways that this is really bad for you are probably three things. So prolonged vomiting and not eating will give you hypokalemia, hyponatremia, and hypochloremia. It'll also reduce your extracellular fluid, and that'll typically manifest as you'll feel awful, you'll be thirsty. As you stand up, because you've decreased your extracellular volume, your body's not able to compensate and you'll get hypertension. You might faint and hurt yourself, which is a bad outcome when you're pregnant and a bad outcome in general. If you do tests on these people, you'll find increased levels of ADH, and because they're dehydrated, they're not peeing as much. And in your more severe cases, in particular due to the hypokalemia and natremia, you can end up with confusion, arrhythmia, and seizures. So the management of this sort of thing is not too difficult, but the big worry is the hyponatremia. It's very easy, especially in pregnant women who are otherwise dehydrated and hyponatremic. It's very easy to overload them with the sodium. If you overload them with the sodium, you're at risk of things like central pontine myelinosis, which is where your brain isn't able to adapt in the change of osmolates as quickly as you'd want it to and starts to lyse. And that's obviously a more severe outcome than anything in pregnancy. So prolonged vomiting can give you Mallory-Weiss tears, and from 30, you might remember things like Boerhaave syndrome, which is a full thickness rupture of the esophagus. It's uncommon, but it can happen, and you can say it in your OSCE to sound smart. And if you have decreased oral intake, you're probably not eating as well. So B12 deficiencies cause anemia and a peripheral neuropathy, often dorsal column. B6 will cause a bit of a peripheral neuritis. And if you lose your B1, you're going to get Wernicke's, which you should probably know by now already. So there's an important differential when someone presents with severe nausea and vomiting though. So a urinary tract infection can give you nausea and vomiting, gastroenteritis, acute appendicitis, biliary tract disease. If you're in the second half of labor, there are some really nasty causes, which Joel and I will talk about a bit later. And things like Addison's can also cause severe nausea and vomiting in pregnancy. You really don't want to have to manage Addison's while someone's pregnant because that involves chronic steroid use. And while steroids are good at the end of pregnancy, where they increase lung maturation, if you're using steroids, especially in your first trimester, it's a much higher rate of gestational diabetes or those actual fetal growth defects. So that's something you don't want to have to deal with. So continuing on, your investigations are as written there. The only interesting one is the hematocrit. So it's because of your concentrated blood volume, which is actually physiological. So normally you have a hemodilution. In these patients, you have excessive vomiting, and you have the opposite. Hematocrit in a normal pregnant lady is low. It does not mean there has been an acute bleed. That's worth considering. The rest of the stuff is fairly reasonable, as you could expect. So in terms of the management, a lot of this management is applicable if someone just has normal morning sickness. Like telling someone, sorry, you have to lose 5% of your body weight for me to give you ginger is ludicrous. So oral fluids is something you use in normal people. IV Hartmann's or saline is fine. Be careful about sodium. Give them all the vitamins you think they need, except oral iron. A lot of these patients are iron deficient. Many women start off pregnancy iron deficient, but they're often iron deficient. If you give oral iron, it actually worsens a lot of their nausea and vomiting, and also makes it sort of harder to, if you ever need to scope someone who's been taking oral iron, it's a pain in the ass. So enteral and parenteral feeding if they're extremely sick, and otherwise use ginger, antiemetics. Ondansetron is the great drug that we learn in med school. You know, you can take it if you're boozing, you can take it if you've just had chemo, but the evidence for it's a lot less compared to things like metoclopramide. Ask your local obstetrician or whoever you've done women's with probably is the easiest way to pick which is better. Prompt allows you a bit of choice, but metoclopramide is often a really dirty drug because of its things like dystonic reactions, which are really bad in pregnancy. Steroids have meh efficacy and can increase your cleft palate risk. And you always use ranitidine. You want to decrease any gastric irritation. And if you give steroids, you necessarily need to give ranitidine to prevent a steroid gastritis. And you want to stop clots because they're hemoconcentrated. If someone's hemoconcentrated either because of dehydration or polycythemia or whatever, they're always at a higher clot risk. So in your history, you take a really top-to-toe history of someone who presents with pregnancy. Obviously, all systems are potentially involved. Things like GI disease and IBD will make it much harder for you to maintain your pregnancy. If you have lupus, you're more likely to clot out your pregnancy and kill the child that way. All their infections, all the vaccinations they've had need to be assessed. I'm not going to go through this in any more detail. So on examination, this is a reasonable exam in your OSCE because the SIM patient doesn't actually need to be pregnant. They can just tell you they're pregnant. You have to believe them. So you want to know their height, their weight, and you can calculate their BMI. I don't know if you need to do that in the room. It's like maths. Blood pressure, a cardiovascular, thyroid, and breast exam. Often your thyroid and breast are a bit dependent on the symptoms. If they have any morning sickness or vomiting, worth checking a thyroid exam. If they're completely fine, no hypothyroid symptoms, you're probably okay. Breast examination if they report any lumps. Do an abdominal examination, see if you can sound the heart. It's always nice if you can tell this is your baby saying hello, but you do not need an antenatal visit, a vaginal or pelvic exam, unless there's been a recent antepartum hemorrhage. It's unpleasant and there's no need to do it, so we avoid it. You do a lot of investigations. So you do a bedside urine dipstick. You're going to do this throughout the pregnancy, again, as I flagged, mainly to avoid things like preeclampsia. Do some random blood glucoses to see if you have to chuck them to an obstetrician straight away because they're already diabetic. Lots of bloods, talk about later. You do a midstream urine, you do an OG. You have to actually confirm the pregnancy as well. Lots of people think they're pregnant and they're just like really late. So a midstream urine can help you confirm the pregnancy. If you think they might be diabetic, there's tests for that. And you're going to do an ultrasound. I'll talk about ultrasound a bit later, but at 12 weeks, you can generally feel a fetal heartbeat. If you don't know where to feel it, you try your left lower quadrant and then you try your right lower quadrant. And at that point, if you still can't feel it, see them again at 17 weeks or something where it'd be pretty hard to miss. Try dating them. You'll not do this yourself, but me, radiologists, will use the crown rump length of the fetus until around 13 weeks. Head circumference is used from then on. And after 20, because there's that biological variation in the size of a baby, you cannot date a baby from pregnancy. That didn't come out right. It's okay. You also want to know that they're having twins. Having twins is really bad if you don't know you're having twins because it's incredibly expensive and you're much higher risk of things like postpartum hemorrhages. So these are all the bloods you do. So a pregnancy test, I would personally open my consultation with a pregnancy test, but by the nature of the OSCE, you'll have to wait until you talk about investigations before you find out if it's relevant. Do a full blood examination, in particular for anemia and thrombocytopenia. Iron studies, because women have a threefold requirement of iron. B12 and folate, again, because of increased requirement. And you want to know if you have to up their folate dose from, I think, 400 milligrams to 4 grams. Hemoglobin electrophoresis for hemoglobinopathies. Blood grouping, all of your antibody screens. At this point, we don't care about varicella. There's nothing we can do. Our immunization is not safe in someone who's already pregnant. Vitamin D levels. And some of you might be ordering things like thyroid tests, renal tests, and liver tests just because you can say them in like acronyms, LFTs, TFTs, and whatever. You don't need to order them. Many of the consultants do private obs. So when they don't order silly tests, and they'll potentially look down at you if you're ordering silly tests because they cost a lot of money. So I'm not going to cover hemoglobinopathy in pregnancy. I think it's taught really badly, but you also don't need to know it for your exam. You can come back and look at this later. It tells you about the sort of genetics of hemoglobinopathy and why we actually care. But blood grouping is important. So ABO is something you should all know from pre-clin and third year. ABO doesn't tend to cause a problem if you have a fetal-maternal transfusion. Does anyone know why? Okay, so your A and B antigens are actually in your blood, obviously, but they're also found in a lot of food. So the reason why you can have a baby of a different blood type to you and not go hemolytic on them is because you've often been exposed to A and B antigens just by your normal life and eating a wide variety of food. But there are a couple of other antigens that are more problematic. The most important of these is the rhesus antibody or the Duffy antibody. The way I remember this is that Duffy dies. Kell is another one that's less common, so the Kell antibody, that'll kill you. And there's the other one that some people test, especially private obs. They'll test for something called a Lewis antibody. The Lewis antibody is an IgM antibody. As you remember from pre-clin, IgM antibodies don't readily cross the placenta, so we don't need to worry about them. If someone has a fetal-maternal transfusion, you refer to prompt. I'm not going to copy and paste things in from prompt here because prompt has them pretty well themselves. So after you actually take a history, you need to do some stuff. And that's a quote from me that I made up a couple of weeks ago. So at your first education, even if they're not experiencing minor symptoms, it's really important that you tell them they might experience minor symptoms because you don't want them to present to emergency department for like nothing important at all. You want to make sure that they're on folate, iodine, and iron. You want to tell them about what's going to happen to their body habitus. So most people know they get larger. Most people know they have to eat more, but a lot of them don't know the specifics of that. You don't need to eat for 2. I think it's like 1 tub of yogurt is enough for like the first 20 weeks. And then after that, it's like 1 tub of yogurt and several biscuits. You don't need to eat way too much. And you want to make sure they maintain their vitamin D and calcium levels. And dietary is always nicer because a lot of your vitamin D and calcium tablets can give you a bit of nausea as well. Reduce harmful exposures. Ask where they work. Not in the way that you ask at the start and ask you, where do you work? I'm a chemist. Okay, so how old are you? You want to find out that they're not working with things like toxic material. You want to make sure they're not doing anything particularly strenuous. If they're in a warehouse, for example, they're going to have to take time off at some point compared to if they're a teacher, they probably only need to take the last couple of weeks off. You want to manage other medical conditions, things like diabetes, social aspects. You want to make sure they've got someone who's going to look after them as well as the baby while they're especially peripartum. And I mentioned routes of care earlier. Again, you need to clarify who do you want to see you. You know, the woman has the choice to be seen completely by an obstetrician if that's what they want. And you also want to tell them what's going to happen at each time they're seen, just so they're not shocked when it's like, oh, it's time for your ultrasound. And they're like, what, an ultrasound? Oh, no. So social education in pregnancy is something that Monash hasn't tested in a while, but there's a good list of stuff. And I think they examined this in 29. So seatbelts still need to be worn. You've got a big mass. The big mass needs to be protected as well as you. Air travel, we try to avoid as you become later in your pregnancy, just because of an increased risk of that you're going to go into labor during your flight. And because if there's anything wrong on your flight, we really don't want you to be deprived of oxygen for the small period of time before you manage to learn how to put a mask on. Exercise is doable. Continue to do exercise. Just don't do anything crazy like lifting weights. Avoid dangerous occupations. Sexual activity levels will change. This discussion ideally would happen while the husband's there, so you can tell him as well. But levels of libido will naturally change during pregnancy, and the recovery rates after pregnancy of libido are extremely variable. You want to kind of tell them that beforehand so the husband doesn't think he's being like neglected or that sort of stuff is fairly common. Most of the time you still can have sex though. There's some old wives' tales that if you have sex towards the end of pregnancy, you can deliberately induce pregnancy. The evidence for that's pretty dodgy, but the evidence is also really old because we don't like doing trials of that sort of stuff. If you have a rupture of your membranes, especially P-prom, then we deliberately avoid having sex because sex is naturally going to push pathogens that are at the lower end of your genital tract up towards the cervix. And if you have that, there's a higher risk of things like infection. Maternity rights, there are lots of rights and like government benefits you get if you're pregnant. You don't need to know any of them. Just be like, I'll refer you to a social worker. And it's always important that you want to make sure they're not being domestically abused. Domestic abuse rates skyrocket during pregnancy and in the postpartum. You want to make sure they've got all the referral services available, and you want to talk to them about their situation and see if they want to press charges and that sort of stuff that you learn in GP. So, ultrasound is really amazing. Does anyone know the side effects of ultrasound? There are 2. No? Okay. So in animal studies, they found that if you apply an ultrasound for too long on a rat's embryo, like over the tummy of a pregnant mum, it burns the embryo. So ultrasound has a known thermal effect. It will literally kill your embryo if you just like live with an ultrasound probe there. The other one that's there is a mechanical effect. Chiropractors will use ultrasound as a way of massaging, especially muscles in the lower back, not so much the upper back. They use their hands, so they can cause those dissections. But in the lower back to affect lumbar muscles, they'll often use ultrasound. Again, we don't know what happens if you ultrasound a woman for a really long time because trials are not allowed. But the utility of ultrasound is not insignificant. Very early on, it's importantly going to tell you about the viability and number of fetuses. At 4 weeks, a good ultrasonographer, so none of us, but like a radiologist, can tell if there's a gestational sac. At 6 weeks, you can see a heart. You cannot see any pulsations for a while. And then we kind of go at 10 weeks, we can tell if there's limb abnormalities. If they've been taking thalidomide or something, you can tell if the baby's got phacomelia. 12 weeks, we can feel the heart or hear the heart if you're decent, as well as you can find out whether or not they've got anything like gastroschisis. So you can identify whether the bowel is inside or outside the abdomen, which obviously will change your management quite significantly. At 20 weeks, we can sort of see their brain in a bit more detail via the Sylvian fissure, and you can also see the circle of Willis and get a very good understanding of the middle cerebral artery. That's important later when you start doing Dopplers of the MCA, which is something you do to make sure that the baby's getting adequate perfusion. And at 21 weeks, up to around there, you can guess gestational age, and beyond that, it's useless. And in the 3rd trimester, we use it for a bunch of things. So we use it for placental position, the length of the cervix, which I'll talk about briefly, fetal weight, wellness, and also things like placental function. So it's also important for Down syndrome screening. So hopefully most of you know this either from peds or from women, so I'm not going to go through it again, but it is obviously important. You look at neutral translucency. A reasonable ultrasonographer, just because they can, will also tell you the crown rump length and whether or not there's an absence of a nasal bone. Both of those are indicators of an increased use of Down syndrome, but aren't used in your calculation of a 1 out of 400, 1 out of 100 risk. There's something that a good clinician will just be able to integrate into that knowledge. You often do your second Down syndrome screening alongside your 20-week ultrasound. So 20-week ultrasound doesn't help. It can tell you if there's other problems, as I flagged before, but isn't used as part of that screening. Just for your own knowledge, there's occasionally an EMQ that looks at non-Down syndrome patterns in some of your enzymes. So if you have a low AFPA, high inhibin, high beta HCG, and low unconjugated estradiol, that's Down syndrome, and that's easy. If everything is low, that doesn't point at Down syndrome. It points at 2 things. One is just grossly placental defects. So the baby's likely to come out small for their age and growth restricted, or specifically for Edwards syndrome. So Edwards syndrome from peds is a severe intellectual disability, micrognathia, low set ears, rocker bottom feet is the buzzword, and they'll often have clenched hands with their fingers overlapping, which is something that normal babies have, but often they grow out of. So an ultrasound guides some of your diagnostic tests for Down syndrome. This is where it's a bit more important. So you should know how to consent someone for both a chorionic villus sampling and for an amniocentesis. The ultrasound is pretty much used to guide where the needle goes, but you'll need to be able to do that in a full consent form. And things like the NIPT, I don't think they're likely to be examined by Monash because half the clinicians don't use them, but it's worth Googling them so you know what they are. The other thing we use ultrasound for, especially in later pregnancy, is something called a biophysical profile, or BPP, which we typically only use if the baby is sick. Something like a 25-week plus baby, we can have a crack at some of these. So we'll do a CTG, and I think Joel's going to talk about CTGs later. We'll look for fetal breathing, fetal body movements, the tone, so whether they're flexor, extensor, or just kind of wavy around in the water of their mum's womb, and the amniotic fluid volume. We typically measure it in several quadrants to identify if there's oligo or polyhydramnios. You do that separately, and you also measure the actual amount to add to your biophysical profile. A low profile is a really sick baby that's more likely to get induced, which is, I guess, probably intuitive. So in the 2nd trimester, women typically do fine. Not much happens to them. There's a couple of bad things, and most of the time they've missed sort of their big antepartum hemorrhage period, which is often around 14 weeks, and they're not really at the point where they're going to develop severe gestational illness. But you want to see how they're going, explore their maternal state. You know, how are you feeling about motherhood? that sort of stuff that most of you will probably do better than me. Sometimes nausea and vomiting are still there. They'll often start to have, but not really complain of things like varicose veins and severe constipation, which they can fix mainly by lifestyle things. Headache, anemia, hypoglycemia start to become common. But here, importantly, you want to ask about fetal activity. So in fetal activity, you want to know, does your baby move? How much does your baby move? And has your baby changed that pattern recently? Women are pretty good at knowing whether or not there's a decrease in fetal activity. They're not really good at knowing there's a decrease in fetal activity when there's no fetal activity. So from lots of movement to little movement is yes, but from small amounts of movement to no movement, they tend to be pretty mediocre. And that's why we often use ultrasound we'll use ultrasound very liberally if someone says they've had decreased fetal activity. You want to know about their preventative medicine, make sure they're taking care of themselves. You'll at this point have the results of all your infective tests. Hopefully if there's a positive, you've acted on something slightly beforehand, but otherwise it'll still be useful. And you see them about monthly. So investigations, there's nothing particularly interesting that you need to do here. And the obstetric examination is of more utility. So they're not going to have a pregnant sim patient because it's effortful and it'll probably cost them a lot, but it's very reasonable for them to have a model pregnant, like a tummy that has lumps and bumps that is really big and rotund for you to do. So you need to start off by organizing a female chaperone. Women in the room, you'll still need a female chaperone, and you want to avoid jargon. I would treat this in the same respect you treat a breast examination in terms of, you don't say drop your gown, you say could you please lower the gown or whatever. Don't use words like reveal. Get them to pee beforehand, otherwise they're going to pee on the bed and like someone will have to clean that up, and as a medical student, not you. And you want to know from a general inspective perspective, are they well, are they not well? Are they obviously distressed or in pain? Do they look anemic? Do they have any generalized edema, which means we might panic and go straight to preeclampsia? What's their height and weight? Do a normal vitals. You will have to actually report the blood pressure. You cannot guess 120 on 80 because it's important. You want to know if there's any thyroid stuff, typically hypothyroidism. Some women get hypothyroidism in pregnancy, but when those women do get it, they get really fulminant thyroid dysfunction. So those patients, you're not going to do a normal obstetric exam. You're going to be doing a thyroid exam on someone who happens to be pregnant. Listen to their heart and lungs, in particular listening for pulmonary edema, or something like a mitral valve prolapse, which can sometimes get accentuated if someone's pregnant. And if they have any pain or lumps, you can do a breast examination. Many of your non-malignant breast lumps can get larger during pregnancy and cause a bit more pain. So the actual examination, you lie them down by their hands on their side. Hopefully many of you have done this, or at least had it signed off by someone in your logbook saying that you've done it. You're going to look for symmetry, obvious fetal movements, especially if they're post-24 and they're not obese. You can often actually see the movements of the baby itself. Any previous scars indicating any previous C-sections. Bulimia nigra and stria gravidarum and stria albicans are just nice things to notice to prove that you're actually looking at the abdomen. They don't change your management in any way. From palpation, hopefully the woman can tell you if there's more than one baby, because otherwise it becomes really hard. But you want to try to identify the number of fetuses and whether they're moving. Do an SFH. A fundal dimple is important. Do you guys know what a fundal dimple is? So big pregnant belly. Normally you have things like a hernia pushing out to the umbilicus are not uncommon, but sometimes there's an inward sucking. The inward sucking means that this lady during partum is at higher risk of a uterine inversion, which is effectively like a prolapse of part of your uterus while you're becoming pregnant and causing traction on your placenta. That's incredibly difficult to manage and needs to be done in a tertiary center. You don't know what side the baby's on. That's mainly an academic question to help you get the heart, actually. So you'll find out what side it's on. The presentation is also often academic, especially if they're not before 30 weeks, but you'll do it anyway. And engagement is something that, you'll have to report, but won't really change your management unless they're completely engaged. So people have told me that a 0 to 6 week uterus in a thin lady is bulky. At 6 weeks, it's a lemon. At 8 weeks, it's an apple. At 10 weeks, it's a large orange, which I don't know. And at 12 weeks is an average sized grapefruit. I've never seen a grapefruit, so I don't actually know. But these are something you could apparently say during an OSCE. I would just say large or small, or actually just measure it because you know how to measure things. So there's a bit more to the obstetric examination. So you want to assess a fluid thrill. You do a fluid thrill mainly because of the edema risk. If they've got edema and a fluid thrill, you want to worry that they're not preeclamptic. And also because if they have a fluid thrill, you might not be assessing fluid within the subcutaneous tissue of the abdominal wall, but you might instead be able to be ascertaining fluid within the actual womb itself. So if they've got oligo or oligohydramnios, they're going to have accentuated or zero fluid thrill. So a slightly positive fluid thrill is normal. Auscultation, you start off with some jelly. Either use a Doppler fetal monitor or a Pinard stat. Has anyone used a Pinard? No, during private land. So a Pinard's a little cone that people put to their ear, and they put their ear really close to the pregnant one's belly. It's apparently very good for hearing arrhythmias. It gives you a nice knockity-knock sound that isn't distorted by a lot of the interference that's present when you do a Doppler. And in a preeclamptic patient, or anyone you suspected preeclampsia, any liver, right upper quadrant pain, any swelling, any proteinuria, you need to assess quite a reasonable neurological status. So any clonus or hyperreflexia, in particular the lower limbs, they're easy to do during an OSCE. The visual fields need to be assessed, and all the other signs that people talk about, things like actual swelling, needs to be identified. The big worry in a preeclamptic patient is that one part of your management is magnesium sulfate. If you actually give someone magnesium sulfate, it destroys their reflexes. So often you'll get a false negative on your reflexes if you're assessing the treatment status of someone who presents with preeclampsia. That's just worth knowing, and probably decrease the mag sulf that you're giving them. So in early pregnancy, people tend to bleed. That's the big problem that people come in with, other than nausea, vomiting. And an OSCE station where a 25-year-old female is at 7 weeks and has some bleeding is a completely reasonable one. It's probably actually too easy for your actual OSCEs, but it's reasonable to understand for the purpose of your EMQs. So the differentials in someone who's young and presents with bleeding in pregnancy: implantation bleeding, which tends to be done by about the 4-week, 5-week status; a spontaneous miscarriage, which we'll discuss later; an ectopic pregnancy; lower genital tract lesions, in particular malignancy and other sexually transmitted infections; perineal infections, which aren't super common in women; gestational trophoblastic disease; and twin demise. So hopefully all of these mean something to all of you. Gestational trophoblastic disease is something you need to know less about. Things like molar pregnancies is a very much upper training of obstetrics type stuff. But this is what you would do. You'd do in a reasonable history. Things like ectopics are more like, I haven't got the history there, but things like ectopics are more common if they got pregnant using IUDs. Things like sexually transmitted infections are things you can often identify via history. And on examination, you need to do an abdo exam, a vaginal spec, a bimanual palpation in case it's an ectopic pregnancy, FBE and hematocrit to make sure they're not anemic, beta HCG, because if it's incredibly through the roof, not just like this normal 120 here, if it's through the roof, you want to make sure it's not gestational trophoblastic disease, ultrasound and Dopplers to check the baby is A, there and B, alive, and vaginal or perineal swabs looking for infection. You'll often, even if you don't suspect infection, you're often still going to do a vaginal swab. The reason you do a vaginal swab there is because you just sort of distorted the area. When you distort an area, there's a chance that you might have introduced an infection yourself, and you want to make sure that you're not able to find any group B strep in particular, because that'll alter your management in terms of providing prepartum antibiotics much later in pregnancy. So why people miscarriage is difficult to ascertain. We think that about half is a chromosomal abnormality. A lot of the time we think it's autosomal trisomy 16 or monosomy X. So people can have X and just a single X and they get Turner's, so X0 is Turner's. Most of the time those people don't survive. Bicornuate and subseptate uteri are causes of miscarriage. Means that the pregnancy isn't able to implant in a region that's going to get sufficient vascular supply. Remembering that the mucosal layer of your uterus is typically the same, even if you have a wall problem, but your placenta needs to be able to embed and effectively grow, and it can't do that if you've got a uteral abnormality. Cervical incompetency, thrombophilia, infection, and there's lots of associations that make you more likely to have a miscarriage. I don't know if UpToDate actually has a cute table describing the comparative risk ratios, but it's probably worth having a look in case they ask you. So there are lots of types of miscarriage. Again, none of this should be new to all of you. So biochemical miscarriage is the most common. The woman often doesn't even know that she was pregnant. She was just 3 weeks late or 2 weeks late and walked it off because it's just a heavy period. When people have a miscarriage that's incomplete, having part of your sort of embryo lying over the cervix is able to trigger a severe vagal reaction that can cause something called cervical shock. That's important to separate from septic shock. And the real big differentiator is temperature. In septic shock, they'll start off really hot and eventually become really cold as they become perimortem, whereas these patients typically don't have any temperature change in their cervical shock. And often, it'll often self-resolve the moment someone sort of moves the embryo away from or out of the cervical region. Your management, you'll probably get better from Prompt or Western than anything I just Control-C, Control-V from those pages. And this is a reasonable table to help you diagnose them. More realistically, you want to make sure if it's incomplete or not incomplete, or if it's completely missed, and those will have different ultrasound findings. So Cervical incompetence is something that I wasn't taught, but then they did ask, I think, an EMQ question reasonably a couple of years ago. So when people have a cervix, you want it to be a nice plug on the uterus. You want to stop that baby from coming out whenever it wants to. And this is the most common cause of a second trimester pregnancy failure. Things like APHs will typically happen in your first trimester, but cervical incompetence happens a bit later. Most of the time it's idiopathic, but people can have an incompetent cervix that isn't able to maintain that plug-like effect. If they have a previous history of miscarriage, of incompetence, if they've had cold knives from gynae cancer, uterine anomalies, previous premature deliveries, multiple pregnancies, or if they have Marfan's or Ehlers-Danlos, so that's less likely. Will typically present as preterm prolonged wrong or as an actual pregnancy failure with just a sudden death. So the investigations we do here is something called a fetal fibronectin. So fibronectin is a particular protein that comes from the fetal part of inside the womb, and it shouldn't really be anywhere else, especially in the vaginal tract. Ultrasound will show you a short cervix. So cervical shortening is normal late in pregnancy and the start of labor, and something called cervical funneling, which is rather than going from a nice long cervix, you become kind of a funnel, which someone used to pour petrol into a jerry can. You also have the bulging of the fetal membrane. So the plug is literally failing. On an ultrasound, you can see that sort of uterus and the fetal membrane is pushing into the genital tract. So your management is tocolytics, iron beta-methasone, just like we do all the time when someone has something mildly bad with the pregnancy. And in the longer term, or if we know it's going to happen, we do something called a cerclage. So cerclage is a tracheoplasty, the tracheus, I think that's the weird Greek thing, the tracheus, not the trachea, is sort of the outer part of your cervix. And what we can do is we can just like stitch it up. You know, the plug of the woman is incompetent, we'll make our own plug. And we just do lots of big stitches that are apparently incredibly painful. And we'll either do that before the pregnancy if we think they're going to have it, or during the pregnancy. And we remove them when we want labor to happen, because otherwise the body is straining against an artificial boundary and they're not able to become pregnant. And that's a really bad outcome. So third trimester again, hopefully most of this shit's already hit the fan that was going to happen. So you see them about fortnightly from 26 to 36 weeks, and then weekly up to week 41. Up to week 41, we start to do more planning for labor. So you do the same stuff you do in the second trimester visit. You ensure them that the baby's happy. You hear the heartbeat. But you want to know about some more symptoms. Things like edema and carpal tunnel syndrome can happen more likely here in the absence of an actual preeclampsia. They're more likely to have that huge gravid uterus pressing on their IVC. A lot of those progesterone-mediated side effects get worse. And this is when you start to do your worry about postnatal depression. You should given you've done psych, it's reasonable for them to expect you to ask at least several of the depression screen and a couple of the anxiety screens. At 28 weeks, everyone gets an OGTT. They were thinking of changing this last year though, so check prompt again or your most recent guide. We give them anti-D if necessary, just anyway at 28 and 34 weeks. And at this point, we don't ultrasound anymore because ultrasounds at this point of some surveys have found they make women really scared. So we don't ultrasound unless we think there's something that's wrong. In terms of labor planning, the normal length of a pregnancy is 36 to 40. Hopefully you knew that already. After 42, things like stillbirths, macrosomia, abruption, postpartum hemorrhages increase, and we'll probably do it at 41. But 2 years ago, they found that all these numbers are for white people. So for the brown women in the room, typically we're likely to induce at 40 plus. Our OSCE last year was the name at least was brown, the patient was white. And when we talked about, because this lady's ethnic, we're going to induce her faster, the examiner vigorously nodded. So that's obviously something that they care about, given the ethnic breakdown of the patients seen at Eastern and at Monash. So the management of obesity and pregnancy, probably going to stop here. I've got obesity and a lot of those liver diseases and pregnancy. They're in the slides, not in your slides, they're in my slides. They'll be passed on soon. So, woo! And so if you have any further questions, I'm somewhere. I'm online. You can message me. All right. Thank you very much.
Oh. It's 10:45. No, okay, the reason I was like, everyone had it in 3 days earlier was so that this shit wouldn't happen to you. Like, it doesn't bother me, but I'm just like, if I give them an earlier deadline. That time management. Okay, that's fine. You can blame me for all of it. You got it done. That's the most important.
Okay, thank you, Sameer. I think you guys will get access to the rest of his slides at a later date. Probably will have some very valuable knowledge. Now we've got Joel, and he's going to be covering labour, birth, and obstetric emergencies.
Hello, how are you going? My name's Joel. I'm not going to profess to be an expert on obstetrics or women's health in general. This will hopefully be a fairly good sort of run through of the fundamentals and what you'll need to know for your exams. So we'll see how we go. So in terms of sources, a really good source of OSCE practice and not many people have used is the women's short answer questions that are on Moodle. So I'd recommend tracking them down if you can. There's a book I've got in my bag that's titled Assessing Fetal Wellbeing, which is really good if you're looking at how to do CTGs. And essentially, if you're looking at guidelines, look at prompt first. If you can't find anything on prompt, look at RAND SCOG guidelines, and then you can Google SA health guidelines as well. They're quite useful. Does anyone not have access to logging into prompt? Or do you all know? Awesome. Contact me afterwards, because you don't have access to prompt, as these clip art people will tell you. You will lose marks because that's the guidelines that they use. So they're super important. And on the wards, make sure you see as many patients as you can. And obviously, for the exam, I'd recommend doing your PEDS MCQs first, because the women's MCQs are really hard and people will get like 60% most of the time. So if you start on PEDS, where people get 90% most of the time, you'll feel really happy and then won't be depressed when you start. So pro tip. Cool, so that's the outline for today. Cool, so first of all, starting off talking about labour. So there's a few little clues that let you know that a woman's starting to go into labour. The first one is Braxton Hicks, or your fake little contractions. There you go. So these don't affect the cervix, and they can change when the woman moves around, or if she sort of changes her activities. Someone's got a bloody show, if their waters break, and sometimes women feel a subjective sort of sense of lightning when the baby drops down to the pelvis. So they're all good clues that something's going on. Cool. So there's 3 stages to labour. So when you start off, you've got a closed cervix and you've got a baby and a placenta inside of you. At the end, you want an open cervix, you want the baby out, and you want the placenta out. So that's pretty straightforward, and that happens in 3 stages. So that's dilation, delivery, and dusting off. So the delivery phase, there's a few clues that you're heading towards that direction. The most obvious one is an uncontrollable urge to push, and that's when the woman's fully dilated as well. So they can be broken up into their own little phases. So the latent phase of stage 1 is when people usually stay at home, they're sort of having gentle contractions and become more and more active from about 4 centimeters onwards, and they'll hit transition stage, and that's when women sort of start screaming. They sort of want to go home or have an epidural. They'll often start telling their husbands they really hate them and want them to go away. So that's all a good clue that the transition stage is happening. And there'll be a bit of a lull, and they'll start pushing, and the baby comes out, and that's pretty awesome. In terms of time frame, just being aware that an epidural obviously adds an hour to the process as well. Cool, so that's pretty much what I said before. Awesome, so if things are going wrong, we all sort of have heard about the 3 Ps before, hopefully. So in terms of power, are the contractions sufficient? Is the woman getting tired or exhausted? In terms of the passenger, is the baby in the wrong position? Is it going to get stuck? And in terms of the passage, is there just no way the baby's going to get through? Usually a good little clue is if the woman's had a baby before. So if she was able to push the baby through her birth canal, that's a pretty good sign that there's not going to be some sort of cephalopelvic disproportion or anything like that. Awesome. So in terms of the 3rd stage of management, you can do physiological if you're a bit of a hippie and just wait for the placenta to flop out. That's generally not a very good idea. So technically you've got like an hour for that to happen, but we usually wait about 30 minutes and then you sort of get going and actually do what you're meant to be doing. So generally you want active management. So this is important to know. This could be an OSCE or on your exams. So 10 units of oxytocin IM. I've never seen like a midwife where you just stab the mum as soon as the anterior shoulder is delivered. Usually it happens a little bit after the baby's born, so you've got a couple of once you get around that. And you guard suprapubically and you sort of just try and gently pull the placenta out. And you cut and clamp and everything is awesome. So in terms of placental separation, there's 4 little clues, which are these ones. The lengthening of the cord is a gush of blood. The fundus of the uterus starts to rise and it goes from broad and soft to hard and globular. If these things aren't happening, that's a bit of a worry. The placenta is not coming out properly, which can be a bleeding risk or an infection risk. Awesome. For some reason, people are pretty keen about us knowing the mechanisms of labour. This is a video that seems to float around quite a lot. If you look at the YouTube comments, a lot of people saying these are mistakes, but it's actually a pretty good video, and if you watch it a couple of times, you'll be able to talk through an OSCE comfortably. This is the mnemonic I use to remember the steps of a minute pinch, which is ED fires. So the head engages, it descends, there's flexion, so that the top of the head pointing out just the smallest area you can. There's internal rotation, which confused me a lot because I was thinking about like the shoulder, like which way is internal, which way is external, but it's just internal inside the mum. And there's extension, restitution, external rotation, which is the head rotating outside the mum, and the rest of the body comes out. So I'll put that in words here too, if you're super keen and don't like videos. It's important to be aware that occipital anterior, which I'll explain in a sec, is the best way for the baby to come out. And the reason for that is you want the head sort of hinging off the symphysis pubis on the way out. If the face is facing forwards, that makes that a lot harder and the baby will often get stuck, which is bad for everyone involved. Cool. So in terms of the head of the baby, it's a lot longer than it is wide, obviously. So it's really important to see the attitude of the head, which way it's facing will make a big difference to if the baby's going to get stuck or not. So there's 3 diameters you could be examined on. So I'm a bit lazy, so I just remember breg is best. And if I see the word breg in the word, that's usually a sign it's the good diameter. So suboccipitobregmatic is the vertex presentation, which is the one you want. A face presentation actually has the same diameter as a vertex, which is pretty cool. And they're both 9.5 centimeters. Then you've got a brow presentation, which is the worst kind, which means the baby's head's probably going to get stuck. And that's 13.5 centimeters. So there's a 4 centimeter difference, which in that tiny little space is actually quite important. That's the panicking, that's a terrifying slide. But the point of that is, don't memorize all the other diameters, it's a waste of your time. Just know the smallest one, the biggest one, and that'll probably get you through. In terms of the fontanelles, I won't spend too much time on this, but if you haven't been on labour ward yet, you can't obviously see which way that baby's head's pointing, so you want to do it by feel. So usually you'll be able to feel the triangle, which is at the back, and there's also a diamond that's at the front. They're usually kind of soft and squishy and hard to feel the shape of, so you can actually feel the lines of the sutures coming out. So 4 lines is the front, and the 3 lines is the triangle at the back. And that way you can see what position the baby's head's in. That's this little picture showing the biparietal diameter. So that's the narrowest point of the head that way. So if the baby's head's flexed and it's 9.5 centimeters in that vertex presentation, it'll make a nice little circle shape as opposed to this big fat oval the brow presentation would present as. That's just showing different attitudes. So you've got the vertex, which is cool, face, which is cool, and then brow, which is bad. And just remembering that triangle is a lambdoid suture if you sort of panic and get confused in an exam. So we've got the lambda at the back of the head, that's the triangle shape, and the triangle is the posterior fontanelle that you're going to be feeling. Cool. So there's also diameters we have to feel in the mum's pelvis, and these are really annoying exam questions as well because they're probably useless for everyone, but there's something we do need to know. So in this plane, I remember Todd. So you're going from the sacral promontory to the pubis symphysis. So the top one is the shrew, the middle one is the O for obstetric, and the D is for diagonal. So if they're asking what diameter goes from the sacral promontory to the superior aspect of the pubis symphysis, the answer is going to be true conjugate. Does that make sense? Awesome. Cool. And in terms of pelvic diameters as well, just being aware that it's widest longitudinally at the start, and then it sort of flips over and it becomes widest longitudinally, widest at the AP axis at the end, which is why the baby's head has to do that weird twisting motion so it can get through the widest point as easily as possible. So it starts off transversely and then ends up facing either the front or the back of the mum. And that's important because the baby's head can get stuck in what's called a deep transverse arrest, which is at the spines. If it gets sort of stuck in that transverse position, that's very hard to sort of pull out. And that's that bispinous diameter where it can get stuck, which is 10.5 centimeters, which sometimes comes up in an exam. And that's a really narrow point. Cool. So here's a question. The distance from the lower aspect of the pubic symphysis to the sacral promontory. I don't really like picking people out. Does anyone want to shout out what they reckon the answer is? Yeah, diagonal, so it's the D in Todd. So TOD, D at the bottom is diagonal conjugate. Awesome. Cool. A deep transverse arrest is likely to occur in the narrowing of which diameter? Bias spinous. Awesome. So these are both questions that have come up before, which is fun. Cool. And then the position of the baby very quickly. So there's the lie, so that's the longitudinal axis. So is it upside down or not? Or is it sort of facing side to side? If it's upside down and vertex, that's good. If it's a breech presentation, that's bad. Pretty straightforward. And in terms of presentation, that's just the face and the vertex we were talking about before. And the attitude is the word that sort of is talking about how bent the baby's neck is. So is it in complete flexion, or is it sort of extended, or is there some sort of mix between the two? And the position is which way the fontanelles are facing. So is it sort of facing the front of the mum or the back of the mum? And they're all important things to be able to tell on your exam when you're looking to see when the baby's coming out. Awesome. So presentation. So there could be a breech presentation OSCE, or there could be just asking some of these stats on the MCQs. So babies are sort of floating around doing their thing for quite a long time. So at 1/5 of the time, at 28 weeks, the baby will be breech, and that's fine. That's not something we're particularly concerned about. When we do start getting concerned is at 37 weeks, where it's gone from 1/5 to about 5%. That's baby's pretty big now. It can't really float around and spin around as much as we'd like. So it's probably stuck in that position. So what we usually attempt to do is what's called an external cephalic version, which means externally pushing on the outside of the mum, cephalic head and version spinning around. So you're externally pulling that baby down to a vertex position if you can. Otherwise, the prompt guidelines usually recommend a Caesar, although you can do it as a vaginal birth. It's much more difficult, and that's not something people are trained for as much these days. So this, yeah, 100%, yeah, that's a bit of a tricky one. So this was an OSCE for us last year, which was fun. It was quite a short OSCE. So external cephalic version is something you do at 37 weeks. So you want to do an ultrasound before and after, because you want to make sure the baby's actually still in breech before you go ahead with it. Same if you were going to do a Caesar for a breech baby, you want to do an ultrasound to make sure it hasn't flipped over by itself, which it sometimes does. So you want to give a tocolytic to make sure the woman's not going to go into labour right there on the table. An empty bladder, and you want to do a CTG, which is a way of checking the baby's heart rate afterwards, because sometimes you're flipping your baby around, obviously the cord can get tangled and stuck, and that would be bad. So sometimes you have to do a Caesar directly after if that's happened. And obviously if they're a rhesus negative mum, you want to give anti-D. So what would the dose be if they were doing it at 37 weeks? 650, awesome, good. Cool. Malpresentations is another fun little thing. So like I talked about before, you want the occiput anterior most of the time. About 1/5 of the time, the occiput will be facing posteriorly. About 1 in 33 deliveries, you'll have a breech baby. And there's sometimes the other things that can happen as well. So in terms of management, they're pretty chill. So occiput posterior, like again, same with breech, people are flipping around all the time in there. So 1/5 of the time, antenatally, there'll be occiput posterior, but only 5% of deliveries will actually end up occiput posterior. Sometimes you can twist them around and get them to go through the right way, but sometimes you have to either pull them out or do a Caesar. And I've been talking about the delivery for breech babies just before. Cool. So the 2 best presentations for a baby's head. What diameter would you want the baby coming out if you could? Breg is best, awesome. So submentobregmatic and subacidobregmatic, which are both 9.5 centimeters. Easy peasy. You can memorize the actual names if you want. So the mento is to do with the chin. The subacid's the back of the head, and the bregma is the bit where the frontal suture meets the sagittal. But obviously, I don't know, you've got a lot of things to learn, so that's probably a bit too much space to fill your head up with. Cool. And what's the worst presentation for a baby? Yeah, it's the very mental one, vertico-mental. And that is bad because the baby usually gets stuck. If they don't sort of fix their head backwards or forwards, usually you just have to do a Caesar. Awesome. Bishop scores. These are fun. So this is to tell if the cervix or not is ready for an induction. So is the cervix soft enough to hang out some syntocin on? So you're going to start the contractions yourself, or you need to soften the cervix first. Some weird white man 200 years ago has chosen the word the ripening of the cervix. I'm not sure what his deal was. He probably wasn't married. So the way I remember it is position CDF. So you've got the position of the cervix, not of the baby. That can be a bit confusing sometimes. And you want the consistency, is it soft or not? You want to see how dilated the cervix is. If it's effaced, and sort of what the fetal station is as well. Whether or not it's worth memorizing this score exactly is up for debate. You need to know what it is, and you need to know how to, what the score actually means. Whether you have to derive the score yourself is up to you. You can probably get away with not knowing the whole thing. So I remember at or below 5, the baby can't arrive. Score above 6, throw some symptom in the mix. So if it's 5 or below, the cervix is too hard. If you start inducing contractions, it's going to get stuck, which is no good to anyone. So you have to ripen the cervix first with a pessary, with a balloon. If the score is above 6, you hang up some oxytocin, or you do an ARM, which is an artificial rupture of membranes. Does that make sense? Cool. Awesome. So now we're actually on to the birth bit. So how can the baby talk to us to let us know how it's doing is an important question. So one of the things it's doing is moving inside the mum, as Sameer alluded to earlier. So if you actually look at the guidelines from prompts, it's really important to listen to the mum. You don't want to just ignore this or think, oh, it's someone being a little bit sort of panicky. This is a really important indicator of how well the baby's doing. So you do a full examination history and you do a Doppler heart rate. If you can't find the heart rate, it's important sort of not to panic the mum or panic yourself, but make sure you just do a full ultrasound to see if you can actually see that little heart beating away. And then you do a CTG. So often the CTG will be normal, but the movements will still be abnormal. The mum's still saying, I don't think something's right. And this is an important sort of indication of how heavily Monash weighs on the mum's feelings versus the CTG. So you still get the baby out if the mum's concerned, even if all the examinations are normal. So you do a full AFI and biophysical profile, which we'll talk about a little bit later. You offer to do an induction of labour. So if they keep coming back going, no, something's not right, you sort of induce them at 37 weeks. Those 37 to 42 weeks is the general window where you expect babies to be born. If it's their first presentation, you do it at 40, which is their date usually. And as Sameer talked about before, South Asian women who are induced at 38 weeks, that's important. It was on our OSPE last year, and the reason it's important is that a Monash professor who figured that out, so everyone went absolutely bananas about it. It's annoying for the doctors because their workload increased like tenfold because they're inducing heaps more women. But the reason they did this is because we induce women normally, white women at 41 weeks, because their risk of stillbirth is 1 in 1,000. But South Asian women, they found to have that risk 2 weeks earlier, around sort of 38, 39 weeks. So we induce them at 38 as opposed to sort of inducing them at 41. That's an important thing to keep in mind. Cool. So we went into more detail about this, but just quickly knowing the biophysical profiles and ultrasound, looking at the baby and seeing how it's doing, and also doing an amniotic fluid index, which is just seeing how much water is floating around the baby. So this is an important concept that can be a good shortcut in your exam. So the way the amniotic fluid is created is essentially the baby is swallowing it and then it's peeing it out. And that should be sort of in balance. And that'll keep the level of fluid pretty much even. If it's, and that level, the normal AFI is, but sometimes it differs, but about between 5 and 24 centimeters is the way to go. If they're drinking a lot more than they're peeing, the water will go down. So that's pretty intuitive. That's usually a sign there's some sort of issue with the kidneys, or there's like a urinary tract issue or a posterior valve issue or whatever. Posterior urethral valve, I should say. And then the other little things it could be are the utero-placental insufficiency, so just not enough waters or blood's getting to the baby to make water in the first place, or they could have ruptured the membranes, obviously, and there's no water floating in there anymore. So the mnemonic for that is just dry rum. That's how I remember that one. Alternatively, they could be peeing way more than they're swallowing, or make there be too much water. That's usually idiopathic, but often if they've got like esophageal atresia or something like that, there'll be polyhydramnionic, and that's a good indication that something's wrong with the upper GI. Does that make sense? Cool. And there's Dopplers. So these are fun. These aren't something we get taught about necessarily, but they are in the exam sometimes. So you can do an umbilical artery Doppler, and whether or not you know about resistance and stuff is probably up for debate. But essentially, if it's high resistance, it's a shit placenta, and the baby's not getting enough blood through. So that could be in something like preeclampsia, and that means it's going to be growth restriction. You can also look at the middle cerebral artery in the baby's brain, and that should be high resistance. If it's low resistance, it means blood's getting shunted to the baby because the baby's panicking and trying to get all the blood to its brain. That's called redistribution or centralization. Often those babies will get big heads but small bodies because all their blood's preferentially going to their central nervous system. And there's something called peak systolic velocity in that artery as well. That's probably not going to be examined on, but essentially if it's thin blood, it's anemic, and if it's thick blood, it's going to be polycythemic. That could be in something like in twins. You've all heard of twin-twin transfusion syndrome. There's something else called twin anemia polycythemia sequence. One gets really anemic and one gets really polycythemic. That would be a good indication there. Cool. So here is a question. 34-year-old, she's got an amniotic fluid volume below the 5th centile. She's hypertensive. Baby's got a big head but a small body. So what's the most likely cause of the low fluid here? So if it's low fluid, it means either an issue with the kidneys usually or the baby's not getting enough blood. The fact that she's got hypertension and the baby's getting a big head but a small body means the baby's not really getting enough blood. So it's preferentially shooting the blood off to the brain and letting its body sort of wither away a little bit. And that's a sign of uteroplacental insufficiency. That's a bit of a tricky one. Does that make sense? Cool. And that was from the, I think that's from the Monash short answer questions on Moodle. So it's a good question to know. Cool. CTGs. So the Latin for that is you're looking at the heart and the contractions and you're looking at those both simultaneously. So if you haven't seen one of these before, essentially the two seatbelts that go on the mum's belly. You've got one ultrasound looking at the baby's heart, and you've got another little sort of transducer checking how much the belly is contracting. So there's going to be two lines. One's in the top, and that's measuring the baby's heart rate. Really importantly, it's not like an ECG. You're not seeing patterns in like the baby's actual heartbeat. It's purely their heart rate and nothing else. And then you can see how often the mums and how hard the mums contract as well. If you're asked by a midwife to sort of feel the mum's belly and like feel how hard the contractions are and when they're coming, that's often a good way to cheat. If you're the CTG on display, yeah, I can definitely feel it. And then you just look at the line and seeing where it's going up and down. So basically you do a CTG anytime you're worried. When there's different indications and stuff, they're done quite often intrapartum, less usually before the people start going into labour. But if you were concerned about a baby, like with fetal movements and stuff like that, you could definitely chuck a CTG on and see what's going on there. So that's Dr. C. Bravado. Have you all heard this mnemonic before? Awesome. It's a good one. So if you're reporting back, you want to define how high risk the baby is. You want to talk about the contractions, but the real meat is the bravado bit. So you want to report back what the baby's baseline rate is, in terms of its heart rate, how variable it is, which is really important. If it's accelerating, decelerating, and then sort of what your overall impression is. Is this reassuring, trace, non-reassuring? Do you want to deliver? Do you want to induce? Or do you want to keep things as they are? So you do need to know these values. So the normal heart rate is 110 to 160. Baseline variability is just like the squiggliness of the line, which I've got a photo of a sec, is 6 to 25. Accelerations, minimum 2 accelerations in 20 minutes, and that's 15 beats a minute above the normal baseline heart rate for more than 15 seconds. So on the line will sort of zig up and then zig down for a bit and zig up and zig down. That's a good thing. It means the baby's responding to what's going on around it. And then no deceleration. So you don't want the heart rate suddenly dropping, then coming back up again. That's a bad sign, which is pretty intuitive as well, which is nice. So variability is actually the one we probably talk about the least in med school, but it's the most important because it's a sign the baby's brain is able to respond to the environment around it and can sort of adjust its own heart rate. So if that brain's not perfused, the heart rate will sort of stop being a squiggly bit and just become a straight line. So it's almost like flatlining, which is really bad. That's a photo from Geeky Medics. It's a little bit artificially drawn here, but essentially if it's really squiggly, that's a good sign that the baby's sort of zigging up and down. It's pretty happy. If it's reduced, it means the baby's not responding. So that could be just that they're asleep, which is fine. But if it's going on for a long time, that's a sign the baby's pretty stressed out. And we probably want to do something about that and get that baby out more quickly. This is from the Women's Hospital. I won't go through all of it, but essentially this is a good thing to go over in your own time. This sort of which signs are good and which signs are bad in the CTG and like how urgently you want to get the baby out. Cool. So you can do a CTG before labour or during labour. When you do it during labour, when you do it before labour, it really has to be a pristine CTG. So if anything's going wrong at all, you probably have to keep the mum there. And that includes you want those 2 accelerations in 20 minutes. When they're intrapartum, you're not super worried if there's not as many accelerations. That happens not uncommonly. It means it's not a normal CTG, but it's not a worrying CTG necessarily. There's a bit of a difference. The real worrying signs are when it stops being a squiggly line and when you start having D cells. Whoa, sorry. That's often the sign that the baby is getting pretty unhappy. And there's different types of decelerations. If it's a prolonged decel, it basically becomes bradycardia. If it happens for more than 3 minutes, you start to sort of panic and maybe get a bolus of some saline or something in there to get the baby more blood. once it hits the magical 6-minute mark, you just take them downstairs and do an emergency Caesar straight away. That's a very unhappy baby. In terms of decelerations, they're all abnormal, don't get me wrong, but early decels are less worrying. I've got a photo in a second. Variable assigns the umbilical cord being compressed. Sorry, it says vein. The umbilical cord is being compressed. That is shouldering, which means it sort of goes up, and then it goes down, and then it goes up and has little shoulders at the top, and then goes back to normal. Late decels keep on going after a contraction. So they'll happen during the contraction and keep persisting afterwards. And the sinusoidal pattern is super rare, but essentially if you have like that little sort of sinusoidal pattern on your CTG, that's a sign of baby's sort of on its last legs, and you want it to go out pretty quickly. Cool. So early decels are just here. That just means when the baby's being squeezed, its heart rate goes down. So that's not normal, but it's not particularly worrying. Late decels are more worrying, which means that that baby's still sort of struggling after it stops being squeezed. And that's something you want to keep an eye on. Yeah, cool. So that's a CTG in a nutshell. Does that make sense? Well, I'd really recommend reading that book I mentioned before, because that's expert. It's got great little examples and stuff too. Cool. So very sort of dummy's guide to how to get a baby out faster. So right at the start, you want to ripen that cervix. So you can either do that by putting a balloon in overnight, or you can do a prostaglandin pessary to sort of induce the prostaglandins either physically or put them in chemically. You can then do what's called a stretch and sweep, which is essentially digitally stripping the membranes away from the lining of the uterus, which again induces prostaglandins and gets sort of labour kicking off. And that's a pretty sort of harmless procedure. Otherwise, you can artificially tear a hole in the membranes and break their waters. Or you can hang up some Syntocin on and get them start contracting artificially as well. So the ARM and the oxytocin IV, what you do to induce, and also you can do those to augment. There's less evidence for this ARM augmenting wise, but that's something people still do quite commonly. Cool. And that's the side of the Bishop's score again, which is this is where it comes in handy. This is where you want to know if you can ripen first or if you can go straight to an ARM and oxytocin. Cool. So in terms of operative delivery, how much time have I got, Jen? Okay, cool. I will go much faster. Sorry guys, so I'll skip through this pretty quickly. So essentially, assisted vaginal delivery is either your forceps or your vacuum. So you're pulling your baby out physically. So that's a picture of forceps at the bottom and a vacuum up the top. So there's different indications of whether or not to trial a ventouse or a forceps, but I'll zip through this. You can have a look in your own time. But essentially, if it's a small baby or it's not a really pristine vertex that you can plug a vacuum onto, that's a sign you shouldn't be doing a ventouse at all. You should consider other options. That's a lovely picture of a ventouse. In terms of forceps, there's different contraindications as well. But essentially, if the baby's going to get stuck anyway, or if it's not right down the bottom ready to pull out, or if it's a face presentation or the baby's known to got some sort of bleeding disorder and you could cut the face and cause some sort of hemorrhage, you probably wouldn't try a forceps either. Skip through this slide. This is a really good mnemonic to know because you might have an OSCE about you have to sort of go on to an assisted delivery and they'll ask you what do you need to do. So you want to make sure the mum's fully dilated. You want that sort of vertex presentation with the occiput presenting. The membranes have to be ruptured, obviously, otherwise you can't actually grab onto the head. You want a catheter to empty the bladder, get as much space as possible. You want the baby to be engaged, and you want them to have pain relief as well. For the sake of time, I'm just going to skip through these. This is just the types of forceps, which should be unlikely to be asked about, but might come in handy at some stage. And there's a few little questions as well, but I'll skip through these. Perineal tears, there's 4 different types of degrees. So I remember SMS rectum. Is it tearing through the skin? Is it tearing through the transverse perineal muscle? Is it tearing through the anal sphincter? And is it tearing through the rectal mucosa? 3rd degree and 4th degree are particularly bad. They're associated with quite severe sort of incontinence long term. And then 3rd degree can be broken up into 3 little subsections as well as in terms of how severe it is. So we do an episiotomy to try and avoid this. So in Australia, we do a mediolateral epiz. So we do a little snip with scissors going this way. So the path of least resistance, if there is a tear, is going away from the rectum, hopefully avoiding that incontinence. Awesome. I'll skip through this too. It's only like 2 slides. I didn't go into a lot of detail here. But essentially, you've got non-farm and farm support. And you can look through that in your own time. It'll take you about 2 seconds. Awesome. Here's the meat. Obstetric emergencies. So there's 3 big emergencies that you're particularly worried about. If the mum's bleeding a lot, if the baby's going to get stuck, or if the umbilical cord starts to spasm and falls out before the baby. So that's PPH, shoulder dystocia, and umbilical cord prolapse. So we'll zip through the management of this because this is quite important. This would be this is very likely to be an OSCE, any 3 of these, because we actually get a whole day of woos, I think it's called, shoots on this. It's because I spend so much time on it, it's important to actually understand what they're talking about. Did I pronounce that wrong? Potentially. Cool. So PPH, there's 2 types. The one we're more concerned about is the one that happens within 24 hours and usually happens straight away. If it's more than 500 mils for a normal vaginal delivery, that's PPH. With a Caesar, it's more than 1 litre. And also, in Monash guidelines, more than 1 litre is known as a major PPH. So there's 4 causes. Because they've got 500 mils of blood zipping through that uterus every minute, it's very easy to lose all your blood supply in like 10 minutes or so. So you really want the uterus to clamp down as small as it can and squeeze all those arteries shut. If it's not doing that, it's a problem with tone. It could be an issue with trauma where something's been cut, like a cervical laceration or something like that. If there's tissue or placenta still stuck in the uterus, it stops it contracting properly, and that also causes the same problem with bleeding, or the person could have a bleeding diathesis. So in terms of treatment and OSCE, first of all, you say exactly what it is and you call for help. And you also want to explain what's happening to the patient and their support team, which is part of the prompt guidelines too. In terms of tone, you want to start a fundal massage to get that uterus as small as you can go, and also do some drugs to make it go as small as you can go to. And that happens 70% of the time, the cause is tone. And the other little treatments are probably a little bit more easy. Cool. So in terms of what you do for everyone, you do a primary assessment, so you do your Dr. ABCD. And the easy things to do are lower the head of the bed and get the mum on that left lateral tilt to avoid that cable pressure. Give them high flow oxygen, and you want to keep them as warm as possible. You get 2 grey cannulae in the cube foss if you can, and you take a bunch of bloods and you start giving them as much as you can as well to avoid them becoming particularly anemic. And you also want to catheterize as well, so the smaller the bladder is, the more space the uterus has got to clamp down and stop that bleeding. A whole spiel about which drugs to use. I'll quickly go through it. So I find drugs names quite hard to remember. So often I assign a character to them to make it easier for myself. So ergometrin, I think of Rene Descartes, which is this guy here, because he said "Frigigo ergo sum." So that, which is probably a bit of a stretch, but is easier than remembering that name. So that's ergometrin. He's a big muscle-bound guy because he likes to clamp down on everything in sight. So you have to remember the doses as well for all of these, as well as the order of the drugs. So it's 250 mics IM. And it looks a little bit weird now that I read that on the screen, but I'm just going to own it. So the worry with ergometrin is it doesn't just squeeze down the uterus, it squeezes down everything else in the body. So if you've got a risk of coronary artery disease, asthma, hypertension, or the placenta is already inside, the placenta is going to get squeezed and stuck inside the uterus, and you have to sort of take it out operatively. So that's contraindicated in most of those conditions. It also squeezes up your stomach and makes you vomit heaps. So metoclopramide is often co-administered here. So the other first line is sintimetrin, which is a combination of ergometrin and syntocinon, or oxytocin. So it's 1 ml IM, which is half-half of Syntin and ergometrin. And that's still got those same side effects. So those are contraindications for using these drugs usually. So the other first line is an oxytocin infusion. So that doesn't have these problems. So that's a little ox swimming in water. Help me remember it's an oxytocin infusion. So that's how my brain works. A little bit of caution here would be that Gareth Weston's book was written like 10, 15 years ago. And these guidelines on prompt are different to what they were last year when I checked them this week. So I'd probably recommend using the prompt guidelines versus that book because they're the most up-to-date thing. So that's a little bit of advice I think would be useful. Cool, and that's a slow infusion. So that's 5 units of slow IV. So those are the top 3 methods of getting that uterus to clamp down. If it doesn't work, or you want your second line, this is sort of your maintenance fluid in a way, you want the same oxytocin infusion, but a different dose and a different rate. So you want 500 mils over 4 hours, and it's 40 units. So 40 units over 4 hours, and that's defined in the prompt guidelines as sort of as like a maintenance way of keeping things contracted. So if in an exam they're like, what do you do next to keep things safe? You do this infusion. Does that make sense? Cool. Third line is a miso soup. So misoprostol, So it's 4 to 5 tablets, which are 200 micrograms each, and they're inserted per rectum. And I sort of ran out of ideas and just Googled F2 alpha, and that was the first picture that came up. So I sort of ran with that. So the fourth line is intramyometrial injections of prostaglandin. You can do up to 8 injections, and you ideally want to do doses 3 to 8 in theatre. So you want to be able to run through that spiel in an OSCE of what you want to do. That's absolutely critical. You know all those doses and all those drugs. So however you get that in your head, that's a good way to go. The guidelines also recently included tranexamic acid. So at the end, you could say, at some point, I could consult with hematology. You can consider running a tranexamic acid infusion. The evidence for that seems to be fairly compelling at this stage, which is good. So there's risk factors for that, which I won't go through. It's operative techniques, which are important. So bimanual compression, you've got one hand inside, one hand outside, and just sort of squeeze it shut as hard as you can. When you hop in theatre, you put a back rib balloon in, which is tamponading from the inside out. If that doesn't work, you do a laparotomy. You do what's called a B-Lynch suture. If that doesn't work, you embolize or ligate the arteries that are leading to the uterus in the first place. In worst case scenario, you just have to cut out the uterus altogether to stop the bleeding. And that's something that's very important to consent for when you're going to theatre and going under GA or a spinal. Cool. So that you need to know all of that for an OSCE. I think that would be a very fair OSCE to receive, which is exciting. So does that all sort of make sense? That's worth going over in your own time. And just being aware if someone's at high risk of PPH, for that active management, you don't worry about the 10 units IM of oxytocin, you just skip straight to the first line for the actual PPH stuff if they're at high risk, even if they're not actually bleeding yet. So the guidelines recommend going your 1 ml of sintimetrin. Cool. I've got a bunch of questions regarding that, but maybe we can hop through that in your own time. Cool. That's about Sheehan syndrome. There's a few sort of eye questions about the pituitary as well. Cool. So this could be a very possible OSCE as well. So this is essentially talking about a woman who's delivering and the head gets firmly pulled back into the perineum and fails to restitute, with the student who's in the room starting to pull on the head and applying fundal pressure. So I don't have time to go through all the questions, but essentially it's really important with shoulder dystocia, which is when the shoulders get stuck behind the pubic symphysis and the head can't get out all the way through. You make sure in the guidelines, it says make sure you say it's shoulder dystocia and you call a code. So there's probably a point for that in OSCE. This is the mnemonic. So essentially call a code, which is a code pink at Monash, and you start the clock. Avoid pushing on the fundus, that'll make things worse. Don't pull on the head, will make things worse. Do an episiotomy to give yourself some more space. You're going to put knees to nips, which is Big Robert's maneuver, which is spelt very poorly, sorry. Which is, it's not even close, is it? It's all right. And then you apply suprapubic pressure, which can be either rocking or consistent. That's not fundal pressure. And essentially put a finger in, push on the anterior shoulder. You can add a finger and push on the other shoulder and try and twist them around. If that doesn't work, reverse your fingers and try and push the other way. If that doesn't work, try and pull out the posterior arm. So it's 30 seconds each. If that doesn't work, put the woman on all fours and start again. You've got about 5 minutes before the baby starts to get permanent brain damage. So this is a really scary situation, which is why people train for it all the time. If nothing works, you either break a clavicle, you cut the woman's pubic symphysis sutures in the middle of her pelvis open, or you can push the baby back in and take it to theatre, by which time the baby will probably be dead. So none of these are particularly optimistic options, but sometimes it's the best you can do. And then you debrief and you document as well. For the sake of time, I won't go through these, but this would be a good thing to go through in your own time because these are potentially quite good OSCE questions. I'm at 5 minutes. Sorry, guys, I'm just going to skip through these questions as well. I do apologize about that. Cool. So there's a woman getting an artificial rupture of membranes, and then, but you're worried because her head's still floating around the abdomen. There's a lot of space for something to fall down, potentially get stuck. So something you worry about when you're artificially rupturing someone's membranes is a cord prolapse. And essentially, someone's got a cord presentation, just means the presenting part is the cord. And if it's cord prolapse, it means the membranes have actually ruptured and that cord has fallen through. And that's bad because the cords start to spasm if they get manipulated, if they're in the cold outside their mum. And also the baby often will just be squishing their own cord and suffocating themselves, which is obviously a disaster. So in any question or any OSCE, if someone gets an ARM and there's a D cell on the CTG or any sort of heart rate change, you really want to rule out a cord prolapse. These are the risk factors straight from the PowerPoint I got last year. Essentially, if there's heaps of room, so a big fluid-filled uterus or a big bub, and the head's not plugging that end of the cervical os, there's a potential for the cord to fall out. And essentially what the guidelines are is you want the woman to go on all fours, someone has to put their hand in and sort of lift the head up the cord, then you have to keep your hand there and stay till you go to theatre and cut out the baby, essentially. So this is a big emergency that's worth knowing. Luckily, the treatment's fairly straightforward. I'll zip through these pretty quickly. That's just a few buzzwords. So Amanda and Zelda are twins who have both had their water break at the same time, which is probably a minor miracle. One's 32 weeks pregnant and one is 38 weeks pregnant. So have a quick think about what the diagnosis would be there if you're familiar with your women's stuff. Otherwise, we'll talk through it. Cool. So if a mum's waters break before a contraction starts, that's prom. If a mum's waters break before a contraction starts and she's before, so if she's before 37 weeks, I should say that's a typo. Then it's either prom or pre-prom. So pre-labour rupture or preterm pre-labour rupture. The risk with these are immediately all the water's coming out, everything's getting shaken up. That's an anatomical picture. And the cord can either prolapse or there can even be a placental abruption in some cases. And in terms of the long-term ramifications, you're losing that physical barrier between the outside world and the inside world, so little bugs can creep up. So you need to replace that physical barrier using a chemical barrier because you're worried about group B strep or strep agalactiae, and group B strep is group B for baby. And that's Brian Cox because his name starts with B and it's strep agalactiae, which sounds like galaxies. So if that helps you, all power to you, but it probably won't. So that just can cause lots of problems in the newborn bub, and it ideally is not something you want floating around in the baby's bloodstream. There's 4 risks for group B strep, which is prematurity, prom, previous sibling with infection, or a febrile mum. So really importantly for this one, for intrapartum prophylaxis, you want IV benpen, which you do need to know. And if they're not labouring yet, you want PO erythromycin. Those are both things that can be on the exam. They're really important to know. So IV benpen, intrapartum, PO erythromycin before labour. So want to protect the brain and protect the lungs if they're preterm. So give Magsulf initially if they're below 30 weeks. You want to give steroids if they're 34 weeks or below. So betamethasone, again, B for baby. You have to know the doses. So 11.4 milligrams IM in the mum, 2 doses at the start and the end of the 24-hour period. So I've got about 2 minutes to go. Sweet, thanks, Jen. We'll get there. So that's a quick table comparing the two in detail, which you can go through in your own time. But essentially, you may on ask you be asked how you can actually ascertain if the waters have broken or not. So you can either do an amnisure or a fetal fibronectin, do a sterile spec, or just take their history. And I'll zip through these. We don't have time to go through them, but essentially these are all potentially OSCE questions about how to manage these things. Just knowing with prom, you've got 4 days max before you want to induce them. So 1 day for every letter. Because maths. And no sex, no swimming, and no insertion in the vagina because there's no physical barrier to protect the baby from infection anymore. Cool. How much have we got? Cool. So in terms of high blood pressure in pregnancy, someone can already be hypertensive. They can become hypertensive after 20 weeks. They can become preeclamptic, which is hypertension with sad kidneys classically, but also just any sort of end organ dysfunction. They can become eclamptic, which is preeclampsia plus seizures, or they can get HELP syndrome, which is considered as a sort of end of the spectrum of eclampsia, which just means hemolysis, elevated liver enzymes, and low platelets. That's an emergency. So basically what you want to do here, I'll just skip straight to the different antihypertensive. This is straight off prompt. So LMNH is the different types of antihypertensives. You can use in pregnancy, they're the safe ones. Nifedipine is equally efficacious orally as IV labetalol. Methyl-dopa is the safest. Hydralazine can cause hypertensive crisis, so needs a consultant there. So that's probably the main things you need to know about those. So LMN, if you're in a bind, I'm trying to remember which ones they are. Essentially, preeclampsia is vessel inflammation caused by toxins from the placenta. So the only way to treat this essentially is to deliver the placenta. Otherwise, they're not going to get any better. And the main risks in the mum are actually not seizures in eclampsia, but stroking. So you really want to manage that hypertension as carefully as you can, but not go too far below sort of 150, 140, because obviously you want the baby getting as much blood as they can get as well. So it's a bit of a little dance. And this is just a management of an eclamptic episode, which could be a potential OSCE. Cool. I'll rip through antepartum bleeding in the last couple of minutes. Sorry, guys, I know this is going over time. But luckily, I kept it very basic. So the most common causes are not these, but these are the most serious. So painful bleeding is an abruption, and painless bleeding is previa, and that's literally all you need to do to get through an MCQ, which is nice. So placenta previa is essentially just when the placenta is at the bottom of the uterus and is blocking the baby getting out. So obviously there's nothing you can do about that except for Caesar, because that baby's not coming out that way. And there's different sort of ways a placenta can get stuck, which is associated with placenta previa. So if it's just a little bit stuck and can't get out, that's accreta, which is bad. If it's stuck through to the myometrium, that's even worse, which is increta. If it pervades all the way through the uterus, that's a disaster. Any of these are usually just a sign you have to do a cesarean hysterectomy. So do a Caesar to get the baby out and then cut out the uterus, because essentially either the placenta is going to get stuck in there and cause an infection, or it's going to cause bleeding. So it'd be very unusual to leave the uterus in any of these conditions. Cool. And that's the sign of placental abruption in the last couple of slides. So just being aware that sometimes the blood gets stuck behind the placenta and doesn't come out. So if it's a firm, tender uterus that's sort of come on abruptly, you really want to suspect this and do an ultrasound. But at the end of the day, the diagnosis is clinical. And then sometimes Monash throws this in here, which is called an ecuvelé uterus. So it's a blue spotty uterus, which is just a sort of pathological way of describing a uterus that's gone through an abruption. So that sometimes comes up in the exams. I won't go through this because that's Linly's biso. And the MCQs. And then we're not going to go through those. So that's it. Awesome. Thank you very much, guys. Sorry that was a little long.
Yours is saved onto the track. Gynae press lecture.
Oh, it's really just 2 slides. But yeah, we'll just do
Okay, no worries. Yeah, it's good, eh? We did yesterday. Oh, no. Oh, actually.
I think probably just people more stressful.
Fair enough. I would be too. I was. Yeah, I did so shit. Yeah, I've just lost my voice, but I'm not sick or anything, which is lucky. I just.
But also, that's weird.
Yeah. Went to death.
Okay.
It's a rest.
All right, thanks so much, Joel, for that presentation. Now we've got Linly, who's going to go through gynae emergencies and pelvic inflammatory disease.
Hey everyone, I know it's been a really long day and it's between now and lunch really, so please concentrate for just a little bit longer. So yeah, I'll be talking about gynecological emergencies and a bit of pelvic inflammatory disease. Just to get you guys thinking a little bit and waking up. So if you had someone with a 21-year-old female presenting with early pregnancy PV bleeding, what sort of differentials would you be thinking about? Or like what are sort of important differentials you don't want to miss? Yep, miscarriage. Ectopic pregnancy, yeah, there's 2 of the major ones. And, oh, so I don't have, oh, is this not the, oh no, it is post-lecture, sorry. I got the wrong ones. Sorry. So yes, so ectopic pregnancy and miscarriage are the important ones, but also it could be physiological, like an implantation bleed. So it could be a live pregnancy, intrauterine, but also don't want to forget about molar pregnancies and heterotopic pregnancies, where you have the intrauterine and ectopic pregnancy at the same time, but that's pretty rare. So on history, you want to probably work out their gestational age, so using their last normal menstrual period and also the regularity of their cycle can help you. Want to know how they confirmed their pregnancy. Was it just through a urine test, a blood test, or was it through ultrasound? And also checking their previous pregnancies. Have they had a history like this before, and how were they? How did they end up? With the PV bleeding, important to quantify the blood loss. Also, if there was any clots as well, could suggest products of conception were passed. Additionally, most of them might have pain. So if it's unilateral or bilateral, and also if they're, maybe it could cause shoulder tip pain when they're having a hemoperitoneum and it's irritating the diaphragm. Your examination, just as if you would do with any sort of women's examination, importantly vitals, checking the blood pressure, heart rate, abdominal examination, pelvic. And with speculum, sometimes you can see the products of conception in the os, and also you can check if the os is open. What sort of investigations are really important to do? Yeah, beta HCG, number one. FBE, yep. I heard transvaginal ultrasound and swabs, yeah. Swabs if you want to do check for PID, but probably, yeah, not so much in PV bleeding. Yeah, so that's most of it. So, and also group and hold and cross match, especially if they're in danger of having a blood transfusion. Yeah, so quantitative beta HCG, if you can compare it to whatever, if they've had one beforehand, and then check the trend of that. But if you don't have that and you're unclear of the diagnosis, then you can do serial beta HCGs. Normally, for an ongoing intrauterine viable pregnancy, it doubles every 48 hours. And once it hits around 10 weeks, that's when it starts to plateau. But if it's less than double, then you're thinking it might be a miscarriage or an ectopic pregnancy. If it's rapidly falling, that's more of a reassuring sign, because it might be resolving ectopic, but it could also be a complete miscarriage. And if it's excessively high, that's when you think a molar pregnancy. Sometimes serum progesterone can be helpful when determining the location. If it's greater than 30, you're thinking it's in the uterus, but if it's less than 30, you might think it's outside. And ultrasound, very important, transvaginal. The general management principles of someone presenting with PV bleeding are, firstly, if they need in resuscitation, so your doctor's A, B, C, D, if they're hemodynamically unstable. Also checking their rhesus status with the group and hold, and if they're less than 12 weeks, you would give 250 international units, and greater than 12 weeks, 625, and that's really important to remember. It's really important to give it within 72 hours or as soon as possible to be effective. And if you have products of conception, either taken from speculum examination or through theatre, you can send it off for formalin, in formalin for histology. And if it's a recurrent, then you probably want to consider sending off for karyotyping. Okay, so now we'll just talk a bit more about ectopic pregnancy. So it's defined by a pregnancy outside the uterus, as you all would know, and it's usually in the fallopian tube, but it can also be present in other places as well. And just this picture illustrates just how common it really is in the tubal region. So that includes interstitial and corneal, isthmic, ampullary, which is the most common tubal, and fimbral. And the rest really is only 1% or 3% in the ovaries. So they're pretty rare. Risk factors for ectopics. So having a previous one obviously would predispose you. Having tubal surgery, whether that's a previous salpingostomy or having tubal ligation in the past. If they've had infection of the tubes before and made them blocked or scarred, and IVF as well can predispose. Smoking can decrease the motility of the cilia, so that can also cause ectopics, and previous cesarean section if they're having a cesarean scar ectopic. I've put IUD there because it's documented in some places, but it's not that the IUD itself causes the ectopic, but if a patient has an IUD and they are pregnant, it is likely that it's ectopic because it's so good at preventing intrauterine pregnancies. So signs and symptoms. So initially they're asymptomatic, which is why it's really important to pick up, because if they're experiencing symptoms, they could quickly deteriorate. Often they'll have pain and it's unilateral, and they may have some irregular vaginal bleeding. And previous to the bleeding, they would have the period of amenorrhea, generally 6 to 8 weeks. They may be tender on examination as well. Features of rupture, these are red flags you want to look out for, and they're all basically signs of hemodynamic instability and distended abdomen from blood being pulled in the pelvis. So investigations, so we all know these investigations we mentioned previously, but when you have a HCG of greater than 1,500, you normally see an intrauterine pregnancy. So if you don't see a gestational sac, then you're thinking the pregnancy is elsewhere. And the free fluid is more, it's indicative of blood. So that's to look out for. Laparoscopy is sort of your definitive sort of diagnosis if it's tubal, and your management as well. Serum beta HCGs are really if the diagnosis is not clear cut. Generally, one beta HCG and vaginal ultrasound is enough. So your management for all ectopics, firstly administer anti-D if they need it. If they're hemodynamically unstable, send them quickly to emergency theatre. But if they're stable, then you might see them outpatient, so early pregnancy bleeding clinic if they don't seem too severe. But if they are severe or the diagnosis is unclear, then you want to consider admitting them and repeating the beta HCG after 48 hours just to see what the trend is. And if it's, again, I've mentioned just before, if it's greater than 1,500 and the uterus is empty, then you're thinking it's an ectopic. When it's an ectopic, you have 3 choices, either expectant management, medical, or surgical. Expectant's really rare in ectopic because often they don't really resolve on their own. You have to either give them methotrexate or surgically remove it. So with methotrexate, the indications are they have to be clinically stable, otherwise you would send them off to theatre. They have to be compliant because especially if it's multi-dose regime, because they have to come in for blood tests and monitoring and extra doses and things like that. And it's for your early unruptured ectopic, so under 8 weeks, less than 5,000 beta HCG, minimal free fluid or minimal blood on ultrasound, the sac being less than 5 centimeters and showing no fetal heart. Or it could be if surgery is contraindicated or likely to be difficult, and more likely if they have a corneal, cervical, or cesarean scar ectopic. The contraindications are if they have a ruptured ectopic, if they have a concurrent intrauterine pregnancy, so like heterotopic pregnancy, if they're hemodynamically unstable, and the other ones are more because these are side effects of methotrexate, so you don't want to exacerbate these. And some of the adverse effects are your general sort of like GI symptoms, but you can have some specific to methotrexate as well. As you all know, methotrexate is also used in autoimmune conditions. And you can look out for some rare ones such as alopecia, bone marrow suppression, hepatotoxic effects, because it directly affects the liver cells. Okay, so there's single dose or multi-dose regimens of methotrexate. With single dose, you firstly on day 1, you would do some baseline things. So some measurements of your weight, height, pulse and blood pressure. You also want to do some bloods, so then you can have some monitoring for any toxic side effects. The dosing I've got there, you can just remember 1 milligram per kilogram. That's probably the easiest to remember, but the body surface area is probably the more accurate dose, and it's an IM injection. It's important they come back on day 4 and day 7 for some monitoring blood tests as well. Generally, you expect a little bit of a rise when it attacks the trophoblastic cells, and that releases beta HCG. So you'll see an initial rise, but it should decline on day 4 to 7. So at least 15% decline. Otherwise, you might give a second dose of methotrexate, or you would consider straight to theatre. After that, you would do weekly beta HCGs to follow up until the levels are undetectable, and that can take 4 weeks. So sometimes you might still be at risk of a rupture and have to go to theatre as well, and you want to counsel them to not be pregnant for 3 months, as methotrexate's toxic for babies. For multi-dose, they need to be admitted for at least 8 days. You do the same baseline measurements, and for methotrexate, it's given on the odd number days, so 1, 3, 5, and 7, with the same dose. And then on even days, you give folinic acid. So, not sure if you know, but methotrexate, it targets the enzyme that converts folic acid into the active form. So when they have methotrexate, they won't have that enzyme working very well. So then you want to give folinic acid, which is the direct active form. And both are IM injections. And then you'd also want to do monitoring bloods as well. So a bit more than the previous one, where you want to do beta HCG on 4, 5, 6, and 7, not just 4 and 7. And you want to discontinue treatment is when you start to decline after 4 doses. The difference between single dose and multi-dose, obviously multi-dose, they have to be admitted, and there's more chance of toxic side effects, but it can bring down the beta HCG faster than just a single dose. So for surgical management, you can have, so it's laparoscopy versus laparotomy, but more likely they'll have laparoscopy. And then you'd consider, do you just cut the tube or do you take the tube out? So if you're taking the tube out, generally the other tube hopefully is normal, so that you can preserve fertility. And then you want to follow up with a beta HCG just in case there was spillage during the surgery. But if you're just cutting the tube, that's generally when the other tube is already lost from a previous ectopic, or it's unhealthy, scarred from infection. So that's when you still want to preserve their fertility, and then you would follow up with a beta HCG again. Okay, so now I'll go on to miscarriages. So defined by involuntary spontaneous loss less than 20 weeks. And it's really common for a pregnant woman to bleed. So 15 to 20% of them will bleed. And out of that percentage, 60% will actually have an ongoing healthy pregnancy. So that can be reassuring to some patients, especially when it's their first pregnancy. They have some bleeding. They might think they immediately will definitely have a miscarriage, which is not the case. But then 30% of these will have failure. So the causes can be split into embryonic or maternal, and most of the time it's due to chromosomal abnormalities, up to 80%. But sometimes maternal factors such as the uterus having congenital abnormalities, such as a bicornuate uterus, or if acquired abnormalities, such as having fibroids, like intramural fibroids. But it also could be an ascending infection that's causing the miscarriage. Something called septic miscarriage can also be a case. Risk factors, so increasing age, malformations as mentioned, infection, thrombophilia, and also chromosomal abnormalities in the parents causing it in the baby, and smoking as well. So there's different types of miscarriages. So threatened is when they have unprovoked bleeding, but then they go on to have a normal pregnancy. Inevitable is when the cervical os is open, but they haven't, the products of conception haven't left yet. So that the inevitable can proceed to an incomplete or complete. Incomplete where it's partially expelled, complete where it's completely expelled, as the name suggests. Missed being the patient themselves feel that they're still pregnant. They don't notice a decline in their symptoms, but the ultrasound shows a non-viable pregnancy. And recurrent is when they have greater than 3 consecutive pregnancies. So have to be one after the other. So this is a picture just to show that it's sort of a continuum of symptoms, and also the miscarriages sort of lead into another. So the first one is when number 1, where they have the miscarriage. So they can still see, they have no symptoms, they feel pregnant, but the fetus isn't viable. Then you have threatened miscarriage, so you start to have a bit of bleed, but that can go on to a normal pregnancy. But then from 3 onwards, that's when you have your inevitable, then your incomplete and complete miscarriage. So you're starting to bleed more, the cervical os is opening, and then you expel the products. So on history, you want to, again, how do they confirm their pregnancy? Through urine, blood, or ultrasound. Having a chronological recall of the events, if there's anything that preceded for miscarriage to happen, what they were doing, and if they noticed clots or passage of the products of conception. And then you would do your normal examination. On investigations, so again, it's similar to how you would work up a PV bleeding patient. So importantly, group and hold, so determining their rhesus status, and doing serial quantity of beta-HCG just to see the trend and if it's a threatened miscarriage or if it's going to be inevitable. So the ultrasound is really important because it can detect if the gestational sac is empty and if there's any fetal heart activity, especially if it's greater than 5 to 6 weeks. That's generally when you can pick up the heart, fetal heart on ultrasound, and it can differentiate between complete or incomplete miscarriage. So they might have passed the gestational sac, but the yolk sac is still in the uterus. Investigations for recurrent miscarriages. So again, if it's greater than 3 consecutive, majority of these are unexplained even after extensive investigations. But you might want to look out for antiphospholipid syndrome, which is common as a common cause for looking at their antibodies, and also ultrasound can check for the uterine abnormalities. You can send the products of conception off for cytogenic analysis and also doing karyotyping on the parents, but that could be quite expensive. Things to consider. For management, always offer grief counselling. It's quite traumatic for a woman to be going through a miscarriage. So definitely offer that, and giving anti-D if required. And there's no contraindications to not conceive the following month. But often the women will not be prepared to conceive so early, but it's important to reassure them that this miscarriage doesn't mean that they'll have miscarriages in the future. If it's a threatened miscarriage, then you would offer symptomatic relief, and then you would want to have closer follow-up and doing weekly ultrasounds to check the fetal well-being. And if it's complete, then you would just offer symptomatic relief. If it's inevitable, incomplete, or missed miscarriage, then firstly you want to check, is the products of conception visualized in the vagina or cervical os? And if it is, that can trigger a vasovagal reflex, so you want to remove it immediately. So if you can, through speculum examinations, that would, and then send those off for histopath. And then if they're severe bleeding, then you give PV misoprostol. If it's not visualized, that's when you consider expectant medical or surgical. So expectant is generally when they're hemodynamically stable, their gestational age is low, because if the greater the embryonic development, the less likely it will be successful and they have to go on to medical or surgical management. But it has a greater risk of incomplete miscarriage or unplanned admissions if they start to have heavy bleeding. Most of the time, it will be expelled in the first 2 weeks after diagnosis, but it also can take 3 to 4 weeks. So a lot of women may want to not have any medical intervention or surgical intervention and choose this, but some might not want to wait so long. So it's important to let them know that it takes a while and they may want more immediate management. So with medical management, you would give misoprostol, and then do serial weekly beta-HCGs until the levels are undetectable. This is for medical managements for if they're hemodynamically stable, they're compliant to have the ongoing weekly monitoring blood tests, and if there's medical support available. So if they live far away and they have sudden heavy bleeding, it's important they're able to reach a hospital close by. So contraindications, because misoprostol can cause bleeding, so you don't want to, if they have a hemorrhagic disorder or anticoagulants, it can be adverse, can cause more bleeding. So having previous history of ischemic heart disease, asthma, and living far away from the hospital or contraindications. And side effects are just your bleeding and pain, so just like your normal, as if you're having a period almost. The fever can be because misoprostol is synthetic prostaglandin, so that can cause a fever, and they might have some GI symptoms as well. Okay, so for surgical management, so that's when they're having heavy bleeding, they're hemodynamically unstable, then you'd consider surgical management. And if the woman wants something done sort of straight away, or they're wanting to fall pregnant again quite soon because of their, if they're getting old, like advanced maternal age, there might be something they want. So, but the risks are generally your normal surgical risks, anesthetic, bleeding, infection, but it can also cause uterine perforation in the curetting. They might not get everything, so you might have something retained, or you might cause something called Asherman syndrome, where you have intrauterine adhesions from the D&C, or it might cause cervical trauma. If they're less than 13 weeks, then you'll do a suction curette. That's also for miscarriage. Blighted ovum is just when you have implantation, but there's actually no gestation or sac inside, or incomplete miscarriage. And then you would also, for both of them, you'd give misoprostol before surgery. Greater than 13 weeks, you'd have to do a dilatation and evacuation because of the size of the products. And then you would also send these off for histopath. So I'll quickly go through ovarian torsion and ruptured ovarian cysts, because these are also gynecological emergencies. So for torsion, so when you have complete or partial rotation of the ovary on its ligaments, and it can be caused by, the most common cause is because it's enlarged ovary. So when you've got an enlarged ovary, it'll just twist upon itself quite easily. Also, if you've got a long fallopian tube, or mesosalpinx or mesoovarian. And also some evidence of sudden increase in abdominal pressure can also cause torsion, but that doesn't happen as often as enlarged ovary. So the presentation, both ovarian torsion and ruptured ovarian cyst are quite similar. They're both sudden onset low abdominal pain, but for torsion it can be colicky as well. It may also radiate to the back flank or the groin. Associated with nausea and quite severe nausea and vomiting. They may have adnexal mass, especially if it's because of an enlarged ovary, and might have cervical motion tenderness and fever. The fever is if it's more later stage and it's getting necrotic. So investigations, again, investigations are the same basically for all of these emergencies. But for the ultrasound, it can pick up any ovarian cysts or peritubal cysts. That may be why it's torting. And also important for the Doppler flow ultrasound, because if it's absent or diminished blood flow, that's when you know it's when it's a torsion. So for management, you want to have prompt surgical intervention. So as soon as possible, or else it will become necrotic and then they'll have to lose the ovary. So they'll go to laparoscopy for detorsion, and they might do a cystectomy at the same time if that's the cause. Especially if it's something like a dermoid or something that won't go away. So the aim is to preserve fertility, but if they're postmenopausal, then that won't be something to be concerned about. So then you might just do a salpingo-oophorectomy just to prevent any torsion in the future. So with ruptured ovarian cyst, again, this presentation is quite similar, but their pain might be quite focal, and they might show signs of peritonitis, especially if it's a dermoid cyst. So I don't know if you guys have all seen the dermoid, inside a dermoid cyst, but pus and everything is quite irritative for the peritoneum. So they'll show signs of rebound tenderness and things like that. Hemoperitoneum, especially if it's an endometrioma, endometriosis, and when that ruptures, that can cause a hemoperitoneum. With bloods, so as your usual, so on the ultrasound, you might see fluid in the pelvis. That might be physiological though, so it's hard to determine if it's physiological or actually blood or pus. For management, if it's simple, so if the cyst is just a corpus luteum, or it's a normal follicular cyst, generally it will go away and it will get better. So you'll just give symptomatic relief and just observe them. But if it's complicated with heavy ongoing blood loss, then again, doctors ABCD to resuscitate them. And then you'd want to do a ovarian cystectomy. So it may have ruptured, but sometimes it forms back together because the epithelial cells are still present. So you might want to do a cystectomy just to get rid of all the epithelial cells. And teratoma, just dermoid cysts. But if that's ruptured, you want to do a good thorough irrigation just to get rid of all the pus. Okay, so lastly, I'll talk about pelvic inflammatory disease. So that's just a spectrum of diseases, including all of the ones up on there, of the upper female genital tract, so excluding the vagina and cervix. And it's often polymicrobial, so it can be a combination of STIs and vaginal flora, or just vaginal flora. So the most common STI causes are your gonorrhea, chlamydia, but it also can be mycoplasma genitalium. The vaginal flora is quite a wide variety of microbes, so when you're treating for them, you have to do a widespread targeting them. So for risk factors, so prior STI, so that can ascend from the lower genital tract upwards, having a young age at onset of sexual activity, having multiple partners with unprotected sexual intercourse, predisposing you to STIs, prior PID, so I'm more talking about acute PID, but you can have chronic and recurrent PID as well, and recent uterine instrumentation or pregnancy, anything disrupting sort of the barrier between lower and upper genital tract. So often they're asymptomatic or non-specific, which is why a lot of them are missed and they go on to having complications. But they might show signs of tenderness, either in their abdomen, adnexal or cervical motion tenderness on examination. They might tell you they have deep dyspareunia, or they might have some abnormal vaginal bleeding or mucopurulent discharge, which is more significant for STIs, or they might just be generally unwell, so non-specific fever, nausea, vomiting. So on bloods, as any infection, you'd probably see elevated white cells or elevated CRP or ESR. You want to do swabs, so checking for STIs, your chlamydia, gonorrhea, and mycoplasma genitalium, and also importantly gram staining cultures. A lot of antibiotics are now becoming resistant to gonorrhea. So you want to also do an ultrasound, checking if there's any scarring of the tubes, if it's been a recurrent PID. Different things to consider: laparoscopy and endometrial biopsy, but they're not necessarily required, because if you're suspicious of PID, you would treat it anyway, and these are quite invasive things. So the management is generally outpatient. You'd only really do inpatient if they're really severely unwell with fever, nausea, vomiting, or if they have an abscess present, or they've tried outpatient and have failed that. So management is split off into if it's a sexually acquired infection or non-sexually acquired, and within that mild to moderate or severe. So for your STIs, mild to moderate, you'd give CAM plus doxycycline. So it's probably important to know the dosing, the route, and also how long the treatment's for. So ceftriaxone, Zithro, or just single dose, whereas Metro and Doxy are for 2 weeks. And if they don't seem compliant, then you would consider azithromycin having the first dose and then the second dose a week later. For severe infection, that's when you do IV. So it's the same treatment, CAM again, but just IV, and the dosing is slightly different because of that. And you want to have 2 weeks of total treatment. If they're starting to improve clinically, then you'd switch them over to oral metro and doxy. But if the cultures come back and the swabs come back and it's Mycoplasma genitalium, then you'd swap them over to moxifloxacin for 2 weeks. In addition to medication, you also want to do contact tracing, and also a lot of the STIs, they're notifiable diseases, so you want to notify Department of Health, and also screen for other STIs as well, as they have increased risk like syphilis and HIV. Advise condom use to prevent future STIs, and avoid sexual intercourse for 1 week following treatment, in addition to rest and analgesia. For your non-sexually acquired infection, so for mild to moderate, it's just oral medication for 2 weeks of Augmentin and Doxy. Quite straightforward. You want to cover a wide range, because it's just, vaginal flora can be both gram-positives, negatives, and anaerobes. So you want to cover for those. And for severe, that's when you hit them with everything. So AGM, so Amoxi, Gent, and Metro, targeting all of them, all IV. And again, switch them over to orals when they start to improve, with a total of 2 weeks of treatment. Okay, so, and then this is the sort of the complications that you look at for pelvic inflammatory disease. And often this might be the first presentation of their pelvic inflammatory disease, because they might have been asymptomatic or having non-specific symptoms. So having a tubo-ovarian abscess, they might present with infertility, and they might not have known they had PID for the whole time. PID can cause chronic pelvic pain, especially with adhesions, and it could predispose to ectopic pregnancies because of tubal damage. And also, does anyone know what the picture is? Yes, perihepatic adhesion, so associated with Fitzhugh-Curtis syndrome. So that's when the infection has spread up into around the liver as well. So that's all I've got, and you guys, good luck for your exams. If you have any questions as well.
Time for lunch.
Okay, it's lunchtime now. All of the vegetarian and vegan options are on this side. And for people who are gluten-free, just stay in the lecture theatre so that you guys can get your wraps. And then come back at 1:30, please.
I'll be there in a second.
Yes, I'm fine. Yeah, I don't know if eating some medical self-inflicted.
Gluten-free. I'll eat it, yeah.
Oh, there's some there, one.
Cheers. Yeah.
Actually, maybe they are okay. Oh, that's okay. Hello, hello.
Yo.
Good stuff. See that? Chilling, eating delicious wraps while everyone else follows you.
Oh yeah.
That's why we're going for it. And then for people have gone, oh, the wraps are good. Yeah.
Mm-hmm.
How you going?
That was you, yeah.
Thank you. I haven't given us to it. I've asked a couple of times.
Only if you were at one on site, you'd know.
Yeah.
It's obviously the real people. Yeah, if you've got a password anyway. Like, it's not like it's a hidden password. Like, if you go to computers there, if you just log into the clinical portal, it says that there. You there for password. It's not like it's trying to hide it from you.
Yes, thank you.
Okay.
There's Derby.
Nothing, sorry, Matt.
What's wrong?
People are using napkins.
Yeah. How have you been? Since yesterday.
No, I'm at home. I had some dinner with my family.
How much?
Just food, really. And then Andrew and I started watching South Park.
Oh yeah. You get along with the family pretty. Sorry. You get along with the family pretty well.
Yeah. Haven't done anything else.
Where are you going? Outside.
We got petrol.
Nice, nice. Always exciting.
Got anything exciting coming up in the future?
I don't remember if I told you. I'm in on Facebook. You know Facebook, it's how they have it like buy and sell pages.
Yeah.
There's a board games one.
I'm getting one for you.
And yesterday I agreed to get a game that I've been wanting to get for a while. Didn't have any like. I mean, I enjoyed it, but didn't have any like burning desire to buy it. And it was like $30. Someone selling it for. It's only like 60. So I was like, yeah, this is pretty good. And then today I might get another game. I think it's pronounced Suro. It's like it's a really weird game where it's like you were either all cooperatively trying to win, or it's last man standing. Those are sort of the two ways to do it. It's you have a map, and each tile has a bunch of lines on it. Sort of imagine a square. Each tile is a square, and the sort of the four edges there's two dots, and the lines will match up between any of those two dots in any configuration. Everyone's got a character piece.
Yeah.
You put them on the top. You put it on the edge of the map. And the aim is to try and get to the center. But you can put the pieces anywhere. You can screw people over, or you can try and all collectively win. It's a very unique game.
We need to play some Gloomhaven on holidays. So good.
Plugging home.
It's actually incredible. Andrew and I have played it so much for shit. I'm so happy that I got it.
Like, I've heard it's one of the best games.
Like, it's actually incredible. And the combination of things I have to know is people. I'm very happy. But yeah, we will have to it's the kind of game that's going to be
Yep.
Hey, maybe?
Jody was telling me yesterday, she wants to get end up with like the Dominion Day going or something like that. Jody was feeling the pinch of no Dominion.
Can we say
Gluten free.
Ryan just wants that whole container to himself. I'm just surprised.
I posted this one, but like.
I'm Hamza, by the way. Since you've been very polite.
Nice to meet you. I'm Emily. Are you one of the 40s?
I am.
One of the 40s who would
I'm for 3 years I did with the ear. So
With the what?
I'm staying down here, so it's like helping you haven't
Oh,
seen me.
oh no, that's all good. Oh, that's good.
When you're not sure, I didn't really register with you.
That's nice.
Sorry, after 10.
Oh, absolutely.
Is the meetup plan that never happened?
Oh.
Too real.
So, although we've been pretty good actually, we've actually had a few successful meetups.
Impressed. Very impressed.
Most of them have been ones that you've organised, but even still.
I haven't organised any of them at all. I organised one.
Well, okay, I say you organised, even though it's still a bit ambitious.
Yeah, there was only one.
Plus your birthday.
I left it was two, wasn't it?
I mean, like, yes, they're technically different. I mean, they are different.
We've done a couple at your house, and we've done a couple at Kate's house as well. Well, one at Kate's house. We've been okay. We've been getting there. I was telling Ryan that we all need to play for and have another holiday.
Man, I've heard it really good.
It was really good. I was just telling Ryan that our combination at the moment is really close.
I love it.
This one's better.
There's three flavors.
This one's like better again.
Yeah, this one's
It's great.
So do you like it? No, no vegan.
Yeah.
That shouldn't be it's obviously not vegan.
Hey, you don't have a
Pardon? That one has egg.
Food outside literally.
It's free food, and we're next to this.
You feel like just grab one?
Okay, beat it straight.
Okay, I don't know.
Perfect, the beat is straight.
Huh?
Beat is straight.
I'm sorry for saying totally.
No, it was justified because they're not so that's the I'm the sure. I'm the stabbing dog. It's more because, like, in the past, they've been, like, right next to the regular food. They're like, oh, right, so grab a wrap.
First table right there, everyone kind of came out to it. Then you realize
She explains it.
okay. So, yeah, I don't know. When she
That's-
said, I thought it was going to go inside. Yeah. So, you know, so vegetarian is a pretty reliable test.
So yeah, telling Emily, you know the Facebook groups that like buy and sell various things. There's a board game one, and yesterday I agreed to buy a game that I've been kind of interested in a while, and today I'm going to buy another one. You heard of Small World? That's what I probably get today, and today I'm probably going to get Zero. Zero, you will like Small World. It has like elements of risk, but like a lot more variety in gameplay and a lot more like actions.
Yeah, sure.
And Zero is just like you have to play it. It's such a weak game, but it's nothing like it.
Cool.
I'll be honest, I can't tell this like the difference between this and the one.
It's solid. I actually don't know what
I thought it would be like.
I don't know what
Yeah, that's the proper ones that.
Where is that from? You know where it's from?
My first
Yeah.
I thought you guys was making
That's just slowly getting good. I reckon the fine print is, I reckon it was assembled today.
Yeah, probably assembled.
So we've got a meeting to do a podcast sooner than that.
Probably.
Sooner than when?
She didn't say specific, but she was like
Exam.
very
Oh,
keen
God.
to play the movie.
Well, let me know.
I haven't mind anything, so useless, but she expressed a lot of, she expressed intent.
Let me know. You know how we could probably justify? Because I like justifying. We can call it an Oscar day. And we all get together and we do like 2 Oscars, and then we just play the Minion for 10 hours.
Isn't that half the study groups that every time you're like, oh, we're gonna have a study group, let's meet up, and half the time you just
Oh, except this is planned. Like
no, you should say that to anyone. We're just gonna have Oscars day, we're gonna have this many Oscars. And like, oh whoops, I left my computer at home. So we're gonna go proper catch up.
But legitimately, hypothetically, Andrew and I were trying to, we're thinking on this last night. At the moment, we're just doing Aussie practice together because, and plus minus a patron. And it's kind of annoying because none of the other South Kickley people are keen to catch up and swap back for Aussies. Yeah. At all, really. Like, he just kind of frustrates me. And sometimes I can't control myself in these GP Oscar stations. It's just like, I'm fat, and I'm like, fuck off, you're dumb. And that's like basically the station. But also, we would like to practice in a bigger group.
Resolving so
yeah.
You can partner violence. So I'm not sure that family therapy is the best.
Fuck off, right? Okay. But like, legitimately, I would be potentially interested in doing some Aussie practice in a bigger group. If you guys are keen to have a couple of people along over swap back, or the week before swap back, or over a weekend sometime soon, even if it was just like 4 of us. Because I feel like that's better than 2. We're going fine, but I was kind of sad when the other stuff. They're not noisy, they're just doing their own. Except for Mark. Yeah. Hypothetically.
Sounds good.
You can get like a proper, as you were saying yesterday, get like a proper 8 station.
Yeah, that sounds like a good plan.
You changed your hair! Have you?
You climbed on the system.
Yes, I did, didn't I? Yeah. I look at you and I'm like, wow, it's so nice. Oh, no, don't cough on my sandwich.
It's not really. Not picking
Don't cough. Let's be honest, I'm getting sick anyway.
They look nice.
You normally have to go with gluten-free. I know you can get gluten-free brands, but I've heard they're
I mean, they're not bad. They're not spectacular.
yeah.
Which one today?
Do you remember eating gluten, right? Like, you guys
You still
know
miss
very
it?
young.
I remember some things.
Hey, Jen. Jen, what time are you studying?
There's whole box.
Like most majority of things,
I feel like most places do. I'm pretty sure they went.
You don't want to try to but it's so, for a month to know, maybe. I have no idea what. And so, like, having less of being, still really if I have to do yeah. But it's
How do you figure that out?
What about when you're traveling?
Europe's pretty good because Europe's got
Yeah. But I'm just watching you guys.
Yeah,
I got no idea. I got no idea.
Not Asian. No. From personal experience, it was pretty bad. We had a friend who lived so we went there, pretty much like we had this he only had 3 or 4
Yeah, that's not right. But as you say, the sources of what sort of made it because but it's still very and oh, sadness is the same reaction to everything.
Yeah, I hate envy something.
I haven't tested the orders yet. I mean, I definitely like it some point, but
Oh, I'm just like, like just looking to it when Andrew went over there. That's the other stuff.
okay, so the honest answer is I'd have to know generally what sources.
What was them?
Oyster sauce is not good for free. Most of it is
I can see it was a whole piece happening.
I think the 2 ones for Lisa yeah, fish sauce is a big one. It's a fine.
I don't know. Yeah, so when I started the only time Andrew actually and we went up to the It's like, I thought we were going to be... I thought we were going to be... And like, everybody got things like 4 or 5.
That's true. You don't know.
Yes.
And that's just so because.
Pretty much you can get food. I had a time where I went to a restaurant. So we get some sushi. Makes the dog feel like eventually they're like, you need water? And they're like, who does that? I actually was that bad at it. Most of the time,
lately, I've been thinking, I want you to be happier. I want you to be happier. When the morning comes, and we see what we've become. In the cold light of day, we're a flame in the wind of the fire we begun. Every argument, every word we can't take back. Cause with all that has happened, I think that we both know the story. There's only for a minute. I want to change my mind. This is the feeling. I want to raise our spirits. I want to see you smile. I know that it's all hard to see. Lately, I've been thinking, I want you to be happier. I want you to be happier. Even though I might not like this, I think that you'll be happier. I want you to be happier. Then only for a minute, I want to change my mind. This just don't feel right to me. I want to raise your spirits. I want to see you smile. No, that is all I have to say. Just too many of my friends and now sipping on cold on a Friday night. Having 2 weeks of drinks and you can barely take us away into the sun. and I don't want to wake up. Feeling like a liar, staring at the stars. I just want to find out if we're wasting time. If we're wasting time. This is a moment that you walked in with a crucial crossroads. Got me looking earthquake. I'm my last drink and I get you high. Wait, then I'll take you back home. Thinking of ways just to get us alone. So things and then I'm crazy. The world is open lately. There's almost so out of my face. Caught up in the moment and I want to taste these few. These cases, caught up in the moment and I want your taste.
Have you been? Yeah. Not yeah. It's paid now. On my side of things. No, yeah. I thought, are you gonna hang around after a bit?
Yeah, you got it's all. Yeah.
How you doing?
Like so?
Yeah, pretty good.
Haven't seen you in ages.
Yeah, I feel like it's been a while.
Are you looking after yourself well?
Sorry?
You looking after yourself well?
Yeah, I'm doing alright, yeah. What have you been up to? You fishing or are you doing a bit of
Yeah.
Fishing? Okay, cool. Alright, well.
I'm not intelligent enough to do it myself.
Nice. I might use buzzwords actually, it's going to be great.
No buzzwords.
No buzzwords? No buzzwords.
I've done it. So what do I do next?
Oh, you got to hook up onto your secondary PowerPoint and
Put in USB, yeah. I can do that. How do I use the software? Save and exit?
Yeah. 1 second. Yeah, just leave half an hour. I'll just sign into this.
I don't even know my password for something.
Oh, really?
Yeah, we'll do it together.
Teacher login. Hello? Oh, it doesn't work. Can you try and give it a go?
Yeah.
Okay, cool. And basically, when they're answering, you'll have a tally, and it'll show you how many people have answered out of like how many people in the room, like here. So, and so people are just like signing in now. Right, and then I would say I've got this.
You
Yeah. Big weekend.
All right, guys, if everyone could log into Socrative and pop in the code Krishna542, we'll get started soon.
Let's see if it works. So it doesn't seem to be loading. For some
Oh,
reason.
really?
Yeah.
I'll just give it a bit.
Sure.
We're done for maintenance. Yeah. All right, so basically all the questions are going to come up on PowerPoint, and then Socrative, you're just going to answer A, B, C, D, E, and then we'll go through it. Everyone welcome Anuj.
Oh. It's closed. Alrighty. So, g'day everyone. By way of introduction, my name is Anuj, and I've been tasked with going through some women's health MCQs today. As Jen mentioned, we're going to use Socrative to make this slightly interactive. I've never used it before, so do bear with me. If you have any questions, you're more than welcome to ask me at the end of this session. We'll keep this short and sweet. Question 1, so a 24-year-old, 24-year-old G0P0 lady presents with a history of 2 years of blood in her urine. She doesn't complain of any dysuria or foul smell. There's no past history or family history of kidney disease. There's blood intermittently present in her urine, occurring approximately every month or so. She does not have painful periods, but is on mefenamic acid therapy due to severe pain in the past. So which of the following investigations is gold standard? So on Socrative, the answer options should correspond to what you see on the screen. Alrighty. So, do I press next? What, Jen? What do I press? Next, or how do we do? Okay, wonderful. I'll give a few more seconds for people to lock in their choices. Alrighty. Okay, sure. So, yeah. So, alrighty. If you could keep the talking to a minimum in between questions, that would be appreciated. So this is endometriosis. As you would know, it's a phenomenon where we have ectopic endometrial tissue. It often presents as dysmenorrhea, pelvic pain during periods, infertility, and deep pain upon sexual intercourse. There's many competing theories as to its pathogenesis. On examination, you often find abdominal distension and bloating. On pelvic examination, you find a fixed retroverted uterus. You might find adnexal masses and bimanual palpation. You often find thickening of nodularities in the uterosacral ligaments, as well as tenderness in the pouch of Douglas. In terms of investigations, first line is a transvaginal ultrasound, but gold standard is a diagnostic laparoscopy. You can also consider a pelvic MRI. And when I post these slides up, these are hyperlinks, and they should take you, if the hyperlink works, should take you to the relevant guideline. Did that work? Oh, it did. So it should take you to the relevant guideline for that condition, okay? It's a very fractured space in terms of guidelines. So this particular guideline is a nice guideline. As you can see, there's guidelines on diagnosis and management and workup, okay? So it's good to be on top and abreast of these conditions. In terms of management, analgesia, both pharmacological and non-pharmacological. So pharmacological things are NSAIDs, paracetamol. Non-pharmacological, so exercise, TENS, mindfulness. You want to induce amenorrhea. As we said, endometriosis is defined as pain during menses. So you want to trial oral contraceptives, an intrauterine device. You can try GnRH agonists, so things like Zoladex. You can also consider danazol, which is an androgenic agent which is used for endometriosis. You can consider surgical amenorrhea, and then you can also consider IVF for fertility. Okay, so again, core learning points here: transvaginal ultrasound, first line, diagnostic laparoscopy, gold standard. Question 2. So if I go back here, maybe, yes. Then next. Wow, awesome. Okay, question 2. A 31-year-old G3P2 woman is in labor. She's had normal antenatal progression, and prior deliveries were full-term, spontaneous vaginal deliveries without any complications. An examination, her BP is normal, heart rate normal, rest rate normal, and her fundal height is also normal. Let's say that she's around 34, 33 weeks, still normal. Her cervix is 6 centimeters dilated, and 60% effaced, normal cervicometric progression. She shrummed 15 minutes ago with clear light call. The CTG is to the top right. What does this CTG show? Alrighty. Good. So, late decelerations. Okay. Next question. Which of the following is the most likely cause of this heart rate pattern? Fetal acidosis,
fetal head compression, fetal hypoxia, umbilical cord compression, and uteroplacental insufficiency. Is it switched? Oh, I haven't switched yet. Sorry. Thank you. I'm too old for this, apparently. Okay, so that's my fault actually. Yeah. First time I've used this. So the answer is uteroplacental insufficiency. It's more of a definitional debate, but we'll move on. So CTGs, we'll come back to it. CTGs are a continuous tracing of the fetal heart rate. They often have two traces, a fetal heart rate and maternal heart rate, maternal uterine activity, and they can include a maternal heart rate. Most of you should be familiar with the system on the right, Dr. C. Bravado, and you should use that in your OSCEs to go through a CTG. So decels, so there's 3 or 4 types of decelerations. You have earlies, lates, variables, you have prolonged. Early decels, as you can see, they're more U-shaped and they happen at the same time, if not before, the peak of the contraction. That's often a sign of head compression, of fetal head compression, which is normal. Late decels are always pathological and it's a sign of uteroplacental insufficiency. And that can progress, so that can lead to fetal hypoxia, but in and of itself, it does not reflect fetal hypoxia. You could consider other things like a rising baseline, and that can progress to a sinusoidal pattern on CTG. But again, give or take. And then finally, your variable decels, and these are a sign of umbilical cord compression. And variable decels in and of themselves aren't pathological, but when combined with other features may or may not be. This is taken from the NICE guidelines as well. It's important to understand what features are reassuring, non-reassuring, and abnormal. So what you find here, so you take the baseline, the variability in decels, and they can come into one of these 3 classes. Depending on the mix of these features, you can either have a normal, suspicious, or pathological CTG. So when we ask for the overall impression, when you're expected to say it's either normal, suspicious, or pathological ECG. Okay? Depending on that overall impression, you'll then take further action. These guidelines come from the Women's Hospital. If it's a suspicious CTG, you ask yourself the following questions. For example, is there uterine hyperstimulation? This is what you would do. If it's inadequate quality CTG, then you'll fetal scalp electrode and so on and so forth. If it's abnormal CTG, then essentially you want urgent delivery or urgent management, and these are the steps you take. Again, it's important to familiarize yourself with these steps. Okay. Question 4. A 27-year-old G1P0 woman is 7 months pregnant with her first child. An IVF, these questions will be uploaded, you don't have to worry. IVF pregnancy for cystic fibrosis with prominent history of bronchiectasis. She presents to the ED complaining of sudden onset right-sided chest pain that is exacerbated with deep breathing and shortness of breath, which began 1 hour ago. No calf pain, it's very stable swelling. Temperature 37.9, BP 130 on 87, pulse 107, respirate 24, oxygen saturation is 90, but increases with 4 liters oxygen via nasal prongs. An examination, we see these crackles at the lower right lung field, negative Hohmann sign bilaterally, X-ray of the chest. Sorry, can you, that's wrong. Get rid of the X-ray of the chest is normal. I changed my mind in the end. So D dimer is elevated, ECG shows sinus tachycardia, right axis deviation, just everything. S wave, Q wave, T wave, everything, okay? But most importantly, and I do apologize, I changed my mind, Chest X-ray has non-specific pathological changes. Wonderful. Okay. So which of the following is the most appropriate next step in diagnosis? So what does the patient have? A PE. Good. Wonderful. So the question is, what would you do next? So let me go back to this. Sorry. What would you do next? So I want to clarify, the chest X-ray is abnormal. Okay. So let's listen up. So the answer is CTPA, and that chest X-ray being abnormal is a very important part of that question. So quickly, thromboembolism in pregnancy. So the relative risk is 4 to 5 times of non-pregnant women. The highest risk of DVT and PEs is around the 3rd trimester and postpartum periods. The management of VTE in pregnancy is very similar, but we don't use warfarin, instead we use heparin. Okay. Investigations. So a D-dimer will naturally increase in the 2nd trimester. So we can't use D-dimer as a positive predictive test. And a modified Wells score will not help us because it can't be applied to a pregnant woman. There are called guidelines for VTE in pregnancy. The most important thing is the chest X-ray being normal or not. I kept saying it's abnormal. As you can see, when it's abnormal, we do a CTPA. When it's normal, we do a VQ scan. So in terms of clinically, this patient had cystic fibrosis with a prominent history of bronchiectasis. So when you do a VQ scan, there's always going to be abnormalities for her lungs because of this chronic lung pathology. Okay, a VQ scan is not going to be very helpful in this patient. That's why we do a CTPA. It's marginally higher radiation nowadays than CTPA, only marginally. But in terms of diagnosis, it's far more helpful. Okay, as you can see, this isn't my thinking, but rather what the guidelines advise us to do. But depending on the chest X-ray being normal or abnormal, we'd consider either VQ or CTPA. Okay, even with doing CTPA, you can consider measures to reduce the radiation load or contrast load in terms of the kidneys as well as contrast exposure. Okay, good. Next question, sorry, I do apologize. Let's press next. A 32-year-old woman undergoes a C-section for failure of labor to progress and delivers a healthy baby boy. Procedure is complicated by significant intra-op blood loss and hypertension, but she's successfully resuscitated. Yay. Postoperatively, she experiences dull, aching, non-localized abdominal pain and nausea, but denies headache, visual change, or abnormal edema. Day 3 post-op, she's passing flatus and remains afebrile, but becomes hypertensive, so 90/40. She's not begun lactating despite her attempts to breastfeed her baby. Blood tests indicate that she's hyponatremic and mildly hyperkalemic. Urinalysis and liver enzymes are normal. What's the likely cause of her symptoms? All righty. Wonderful. Sheehan syndrome. The Sheehan syndrome is a very common complication of PPH or any massive blood loss, really. Okay. So it's postpartum or partum infarction of the pituitary due to blood loss and hypotension. So during pregnancy, the pituitary increases massively because it has to produce excess amounts of FSH and LH compared to normal, and therefore has increased vascular needs. But the blood supply actually doesn't increase. If not, the vascular blood supply of the pituitary is actually a bit compressed because of its enlargement. Because there's a blood loss and there's a mismatch between vascular needs and blood that is actually being provided, it then infarcts because of a relative ischemia. What you get is panhypopituitarism. So you get decreases in growth hormone, prolactin, TSH, ACTH, FSH, and so on and so forth. Okay, so panhypopituitarism. The most common thing they present with is that poor lactation because of a lack of prolactin. But in the future, they will have complications of all of these deficiencies. The reason why this patient had the electrolyte disturbance is a lack of aldosterone being produced. And that's as a result of a lack of ACTH. Okay. Good. Next question. 29-year-old woman, G2P1 at 37 weeks, is admitted to hospital. Previous pregnancy is uncomplicated. The normal vaginal delivery, term 3.5 kilograms. Current pregnancy demonstrates a bridge presentation at 30 weeks gestation. Wait, what? Sorry, I got confused. It's fine. Let's say she's 37 weeks. I repeat. Oh, okay, that's fine. So at 30 weeks, she was breech, but now she has persistent frank breech presentation with a weight of 2.8 kilograms. No fetal or uterine abnormalities noted. She has intact membranes, closed Oz, fetal heart monitoring is reassuring. Which of the following is the most appropriate next step in management? I do apologize. I wrote this question many months ago for one of the tutes I was running. Okay. So essentially, this patient has a persistent frank breech presentation at 37 weeks now. What would you like to do? A C-section, external cephalic version, or ECV, internal podalic version, or IPV, allow for a normal vaginal delivery, or consent for forceps and instrumental delivery.
Okay, she just popped in.
Alrighty, good. For this patient, we'd offer a external cephalic version. Okay, question 7. When assessing the appropriateness of ECV in the previous patient, the same patient, which of the following is not an absolute contraindication? I think there's only one right answer. Yes, make it is not. So which of the following is not an absolute contraindication for ECV? So for example, A would be things like placenta previa, okay, where you must do a cesarean delivery. And D is only for uterine anomalies, not fetal anomalies. The fetal anomalies, depending on what they are, they may or may not be contraindications. So that's not an answer choice. Okay. So there are many types of malpresentations, and a breech presentation is one of them. There are 3 types of breech presentation to your left: frank, complete, and footling. For a footling breech, you must perform a C-section, but for the other 2, you can offer an ECV or vaginal breech. 25% of fetuses less than 28 weeks will have some sort of breech presentation, but most will become cephalic by 35 to 36 weeks. In terms of management options, for frank and complete breeches, you can offer an ECV, a vaginal breech delivery, or elective cesarean. That's what you can offer. In terms of guidelines, any woman around 36 to 37 weeks must be offered an ECV and counseled an ECV, but it's up to them to choose. Most wards are no longer upskilled to do vaginal breech deliveries. So it depends on where you are. So an ECV can be performed when no contraindications for vaginal delivery exist. It's performed with a tocolytic, because when you're manipulating the baby, it can often induce contractions and labor. A fetal ultrasound must be performed before. Anti-D should be administered to rhesus-negative mothers. Should only be done when emergency C-section is available. Okay. To the right are the contraindications, both absolute and relative, for ECV. And this was an OSCE station for us last year in terms of consenting a patient for ECV. Okay. So the level of granularity that I'm going through isn't misplaced, perhaps, for your OSCEs and your MCQs. Okay. These guidelines, or this particular guideline, is taken from the RCOG website. And again, once you get access to this PowerPoint, you can click on it and you can go to the link. Okay. Major or absolute contraindications include where you have to have a cesarean delivery, APH within the last 7 days, abnormal baby, abnormal mum, rupture of membranes, because that again, induced labor, or multiple pregnancy, the exception of trying to deliver the second twin or the smaller twin. Okay. Question 8. This is a good question. 37-year-old woman presents because of intermenstrual bleeding and heavy menses. Past history includes hypertension, type 2 diabetes mellitus, and hyperlipidemia. Blood pressure is 144 and 86, BMI 40, physical exam, unremarkable. On endometrial biopsy, it shows complex hyperplasia without atypia. She has 3 young, healthy children and has had enough of them. It's the most appropriate next step. Offer hysterectomy. Put her on cyclical progestogen, so progesterone. Low-dose oral contraceptives. By that I mean like low-dose COCP or any other oral contraceptive. Estrogen replacement or endometrial ablation. Alrighty. Cyclical progestogens. What does this patient have? Endometrial hyperplasia. So it's hyperplasia with the risk of progression to endometrial adenocarcinoma, there's glandular structures in the endometrium. It's divided into simple, complex, and with or without atypia. Endometrial hyperplasia can regress with both conservative as well as medical management. Risk factors are essentially an increased exposure to estrogen. As you would know, estrogen encourages the proliferation of endometrial tissue. So things like HRT, COCP, and also increased BMI. So with increased BMI, you have peripheral estrogenation of testosterone. Okay, so you have increased estrone production. Management of endometrial hyperplasia depends on the type, so the grade, and also on the fertility requirements. Really important points when it comes to management are: number one, you would never give estrogen therapy. Okay. Number two, you never ablate. I mean, never. Number two, the reason why is because if you ablate, what you do is you prevent any symptoms of the hyperplasia. The most common symptom is bleeding. Once you ablate, there's not much bleeding. And what happens is you often mask further atypical changes beyond the part which you've ablated. So if you've ablated just the superficial areas, it can be atypia a bit deeper than that. Okay? So ablation is never foolproof. There may be further atypia. So you never ablate a patient with hyperplasia. Okay? You can ablate them if they just have heavy menstrual bleeding, if that's the only cause of heavy menses, but not for hyperplasia. Management. Okay, so this is the ARCOG guideline for endometrial hyperplasia. You can read through that in your own time. The most important thing essentially is, so we don't give estrogens and we give progesterone. Progesterone stabilizes the endometrium and encourages regression of the hyperplasia. How do you give that progesterone? Either you can give like progesterone in the form of an IUD, or you can give it cyclically, in terms of oral progesterone. Okay. In terms of follow-up again, you would follow the outline here, but essentially you surveil them at a minimum of 6 months, and you discharge them once you get 2 consecutive negative biopsies before you discharge them. Okay. Up here, we talked about those hyperplasia categories, so simple, complex, with or without atypia. As you can see, without atypia, so no atypia, a very, very low progression to endometrial cancer. But the moment you have atypia, then you're going to change your management plan. Okay. So if a patient has complex hyperplasia with atypia and they want to have further children, you put them on a 6-month kind of trial course of kind of low dose progesterone, or you ask them to have as many babies in as quick a period as time possible, and then you take out the uterus. Wonderful. Okay. Question 9. Tanya is a 45-year-old woman who attends your GP clinic for a general checkup. Vitals are normal, BMI 31, examination unremarkable. The scripts for HDN are in order. She's heard that there's some new changes to the cervical screening program. And she understands that there have been changes to the frequency of testing. The last pap smear was last year. When should she have her next screening test? And what should she have? Okay. Just a disclaimer, I had to learn this myself, so hopefully it's right. Okay, so what would you want? A pap smear in 1 year, a pap smear in 4 years, HPV genotyping in a year, HPV genotyping in 4 years, discharging from clinic, because it's too hard for you. And refer to gynae clinic for urgent colposcopy. Wonderful. Good work, everyone. So you're right, it's HPV genotyping in a year. Okay. Next question on CST. In 2019, she returns for HPV screening because it's in 1 year. Good. Her CST returns as being HPV positive, but it's strains 16 and 18 negative. You perform LBC, liquid-based cytology, and that returns as low-grade squamous intraepithelial lesions. Okay. So what would you recommend next? No further screening at all, discharge, HPV genotyping in 5 years, HPV genotyping in 1 year, HPV genotype plus LBC in 1 year, or refer her to colposcopy. Oh, wait, what? Ooh, that was split. Okay. So first of all, I think this is a really good. I think it might be a good OSCE station, depending on what the faculty thinks is good or bad. In terms of just basic concepts, instead of doing pap smears, which is looking for cell atypia, we're doing genotyping every 5 years. Starts at 25 years and ends at around 75. If you've had a pap smear, your first HPV genotype is 2 years after the previous test. That was for the first question. Okay, and these are some other indications for CST. To your left is the pathway. So essentially, if you've had HPV, and depending if it's 16 or 18 positive, you'll do a different reflex LBC. If it's not 16 or 18 positive, and it comes back as low-grade changes, then you just repeat the test in 12 months. Okay? Only if it's positive then would you consider doing LBC. You can't judge that now. Okay? So we would just repeat it in 12 months' time. Okay. A 32-year-old woman, G1P0, is in active labor. Lumbar epidural anesthesia is being used for pain control. She's having contractions every 2 to 3 minutes. The cervix is 4 centimeters dilated. Fetal heart rate is reassuring. Her blood pressure is 90 on 55, so a bit low, and heart rate is 120. What's the most likely cause of her hypotension? Decreased myocardial contractility. Yep. Intravascular fluid loss. Blood venous pooling. Blood redistribution to the upper trunk. And CNS involvement. Okay. So they've given her an intrathecal anesthesia as opposed to epidural, perhaps. Or maybe that's what happens when you give anesthesia below the pelvic line, pelvic pain line. Huh? Why not? Any reason why not? Oh, okay. Alrighty. Kieran, you seem to be having a great time.
Yeah.
What's the answer?
I went to A, but I'm not too sure.
Okay, that's okay. Could you explain why it's E?
Because is that the epidural?
Yeah, so this is epidural anesthesia, yeah. But can you explain why you thought it was E?
Because it's like they increase the sympathetic drive.
Sure.
So
Sure.
Yeah, I guess the blood could be pulled through.
Okay, it's a good idea. So this is a blood venous pooling. It's okay. I'm sorry for picking on you. I love you too. Okay. So epidural anesthesia, a very common side effect is hypotension. And it happens around 10% epidural blocks. There's two essentially, the way it works is not because of CNS involvement really, but anyway, there's a sympathetic fiber block, as you said, and that leads to vasodilation of the lower extremity vessels. That leads to blood pooling, and that leads to hypertension, but it's not CNS involvement. Okay, so you're right in your thinking. What it can do is it can slow the progress of labor, both first and second stage, as you would expect an increased hour for the first stage. Because of labor being slowed down, there's an increased risk of instrumental delivery due to epidural anesthesia. So when you consent patients, that's something you should be wary of. Question 12. Sorry, question 12 is a bit hard in terms of how I've formatted it. I do apologize. 41-year-old G1P0 at 32 weeks presents a routine antenatal checkup. She's noted to have an SFH, so fundal height of 36 centimeters. Examination is otherwise normal. Antenatal history is unremarkable. The patient has denied aneuploidy screening. Upon investigatory ultrasound, the following is observed. So that is not the baby's heart, that's the baby's stomach. stomach, that thing, stomach. And you can follow that down. So that's the ultrasound. Okay. Alrighty. The question hasn't come yet. Okay. So during second trimester screening, which of the following results would you expect? Oh no. Okay, let's move on. Oh, awesome. So the answer is B. Good work. In terms of aneuploidy screening, it makes a recommendation for further invasive diagnostic testing, so chronic villus sampling, amniocentesis. Screening tests give an individual risk by adjusting age-related risk times of results. How to remember the results. So for Down syndrome, mnemonic is high, so H and inhibin are high, and AFP and estrogen are low. Okay. The opposite end is Edwards syndrome, where everything is low. Okay. This is for second trimester screening. First trimester screening, obviously, they have different results. You don't have 4 hormones. That's stomach, duodenum. Where's the jejunum? Where's the ileum? This is duodenal atresia. So for this question, sorry, do you mind? So for this question, essentially you have a woman of perhaps an older childbearing age. She hasn't had any other antenatal testing, and she's 36 centimeters. Okay, so is that normal in terms of the size? No, so it's a bit larger. Okay, and so this combined with this duodenal atresia picture looks like polyhydramnios. As we know, duodenal atresia is associated with Down syndrome. Okay, so you have older mother, duodenal atresia, polyhydramnios. What do you expect this patient to have? Down syndrome, so the baby, and what are the results as expected? Okay, question 13. 76-year-old, sorry, I'll put next. Wonderful. A 76-year-old woman presents with complaints of severe vulvar itching for the past month. She's tried topical lubricants without relief. Physical exam shows multiple vulvar excoriations. The vulvar skin is thin, dry, and white in color. It's hard to visualize the labia minora. What's the next appropriate step in management? HPV genotyping. vulvar punch biopsy, radical vulvectomy, estrogen creams, wet mount smear, and vulvar swab plus MCS. Okay, so what would you do next? Bless you too. Alrighty. I've been told to speed this up, so I will. So, what's the next most appropriate step? So, vulvar punch biopsy. Oh, not bad, not bad. Good. Okay, next question. So, we've diagnosed lichen sclerosis. What's the next most appropriate step in management? Radical vulvectomy, topical corticosteroids, topical estrogen, cryotherapy, or topical clotrimazole. Yep. So we have lichen sclerosis. What's the next most appropriate step in management? Alrighty. So the answer is, so I do apologize, we do have to pick up some slack. So, good, topical corticosteroids. So lichen sclerosis and atrophigus is a chronic inflammatory condition of the anal genital region. Presents with pruritus, dyspareunia, dysuria, and painful defecation. On examination, or you see the skin, you see leukoplakia, which is porcelain white macules, an atrophic, very cigarette paper-like skin, and you see sclerosis and scarring. So what you get is this leukoplakia, and that's a figure of 8 sign. Okay, so white around, and that's known as a figure of 8 sign. But sclerosis and scarring leads to essentially fusion of the clitoral hood, and also kind of like obliteration of the labia minora. Okay. It's associated with a slightly increased risk of squamous cell carcinoma because of this chronic autoinflammatory condition or autoimmune condition with a 5% transformation rate. Management is corticosteroids. It's very common. Question 15. An 18-year-old woman presents with vaginal pruritus and discharge. She's had 2 sexual partners in the past 6 months, and she's on the COCP. She has no other medical problems, and she's not on any other medications. She has no allergies. An examination, temperature is 37.2, BP is 102 and 72. Mucopurulent cervical discharge with friable cervical mucosa is seen on speculum. And remainder of examination is unremarkable. Under microscopy, because you do that type of stuff, you see numerous neutrophils with gram-negative diplococci. What is the most appropriate management for this patient? Alrighty. So the answer is I am Kef and oral azether. Okay. So the patient, what does the patient have? The patient has Neisseria. Neisseria is often asymptomatic, but if it were to be symptomatic, you get increased vaginal discharge, low abdominal pain, and in men, you can often get proctitis with rectal bleeding, discharge, and pain. Investigations are either a NAT, a nucleic acid amplification test, or a swab plus MC&S. It's a very common exam question, when to use which one. If the patient's asymptomatic, you use the PCR. If the patient is symptomatic, you use the swab plus MCS, okay? So this is really important. Diagnosis, treatment, okay? Asymptomatic, symptomatic. In terms of management, you give often an IM dose of ceftriaxone plus 1 oral dose of azithromycin. The reason why you use 2 antibiotics instead of 1 is because these patients often have chlamydia as a co-infection, and also you're trying to prevent or treat often macrolide resistant or cephalosporin resistant gonorrhea. Okay, so hence the dual therapy. Okay. Question 16. A 14-year-old girl is being evaluated for short stature. She's at the 6th percentile for height and 20th percentile for weight. Blood pressure is elevated in the upper extremities, but low in the lower extremities. The lungs are clear to auscultation. Which of the following is most likely present in this patient? High inhibin, low growth hormone, high estrogen, high FSH, high testosterone, or low luteinizing hormone. Alrighty. Oh, sorry, my fault again. Okay. So the answer was high FSH. Okay. There we go. Okay. So this patient has Turner syndrome. And those are the physical characteristics of Turner syndrome. In terms of the examination, in terms of the heart, what pathology does she have? She has coarctation of the aorta. It's associated with Turner's. Now, importantly with Turner's, people with Turner's are often infertile because they have streaked ovaries, okay? They have ovarian dysgenesis. If they don't have ovaries, they're not producing what? They're not producing estrogen or progesterone. If you're not producing estrogen and progesterone, then you're going to have negative feedback loops, and so the body's going to compensate or try to compensate by increasing FSH. Okay? Trying to bombard whatever small ovarian reserve they have with FSH. Okay, so T is the answer. Okay. It's also important in terms of auscultations to know the long-term associations or complications of Turner syndrome for things like Hashimoto's, rheumatoid arthritis, and so on and so forth. That's been an auscultation in the past. Okay, question 17. Sorry, I do apologize. A 24-year-old African-American woman presents in her 35th week of an uncomplicated pregnancy with numbness and burning in her right palm. She says the sensation is so uncomfortable that it frequently makes it difficult to sleep. Which of the following is the best initial treatment for this patient? Indomethacin, oral corticosteroids, local corticosteroid injection, wrist-splinting, decompressive surgery, and ketamine. Alrighty. So, wrist splinting, wonderful. So, we all know this is carpal tunnel syndrome. Okay. In terms of why it often occurs in pregnancy, two reasons. One is because estrogen leads to depolymerization of ground substance, and that leads to interstitial edema in both the hands and the face, so swelling. Also, progesterone is a potent vasodilator, another cause of edema. In terms of first-line management of carpal tunnel syndrome, wrist splinting and other conservative managements are first line. Local corticosteroid injections are generally second line. Now, generally, we'd give these patients some analgesia, so NSAIDs, but it'd be contraindicated in this patient because of an increased risk of miscarriage, as well as premature PDA closure in the fetus. Because how many weeks along is she? 35 weeks, okay? So we don't want to close the PDA too soon. For this patient, that's why we want to avoid indomethacin, okay? Good. Question 18. 24-year-old woman delivered a healthy baby by vaginal delivery at 36 weeks gestation. She's had a prolonged premature rupture of membranes and forceps required. Day 2, postpartum, she complained of fever and chills. She cannot breastfeed because her nipples are really tender. Temperature 38.5, BP 120 on 55, pulse is 92. Bimanual examination shows a tender uterus and foul-smelling lochia. Nipples are cracked, but there's no surrounding erythema or warmth. So what is the probable diagnosis in this patient? Is this normal? Is this puerperal mastitis? Is this endometritis? Is this deep venous thrombosis? Or aspiration pneumonia? Alrighty. Good. So endometritis. Right. Next question. Same stem. Which of the following causative organisms is most likely responsible for the patient's condition? Chlamydia, could be Streptococcus, Neisseria, Staph aureus, E. coli, Klebsiella, or is it a polymicrobial infection? Oh, again, I apologize. Yeah, this is my fault. I don't know how this even happens. Yeah, so this is actually a polymicrobial infection. So the 45% are right. So when it comes to puerperal sepsis, there's 4 main causes you should always exclude. So there's actually a very good OSCE station: UTI, mastitis, endometritis, and infection of perineal repair. When it comes to endometritis, you should always suspect it if the fever is greater than 38. Risk factors are prolonged rupture of membranes, prolonged labor, C-section, or use of intrauterine pressure catheters or fetal scalp electrodes. In terms of history, examination, fever, uterine tenderness, foul smelling lochia, because of retained products of conception often. This is like a monachism. Often the patients are described as having pain on wearing their seatbelt or pain on pulling on their pants. Trust monach. In terms of management, you hit them hard. So intravenous scam, so gentamicin, amoxicillin, metronidazole. Essentially, because it's a polymicrobial infection, we often use broad-spectrum antibiotics. So this is a really good rule of thumb. Is that if it's polymicrobial, it's broad-spectrum. So things like, diabetic foot ulcers progressing to osteomyelitis, again, polymicrobial infection, again, you give IV tazocin. Okay, so good rule of thumb. Broad-spectrum antibiotics are used for polymicrobial infections. Okay, as I said, puerperal sepsis and those 4 different causes. It's a really nice OSCE station because you can go through each of these very different clinical entities and ask different cluster questions and examine them in different ways. Okay, question 20. A 15-year-old girl is brought to the physician by her mother because she's not begun menstruating. She's otherwise healthy, no medical problems, vital signs are normal. Physical exam, normal. Ultrasound confirms the presence of a uterus. Which of the following is the next step in management? Order estrogen levels, order an MRI of a pituitary, order serum FSH levels, karyotyping, GnRH stimulation test, or a GnRH challenge test, either one, or just reassure the patient. Okay, so let's go through this. This patient has not begun menstruation. Everything else is normal. She has a uterus. So she's got no primary sexual characteristics, and she doesn't have any secondary sexual characteristics either. Okay. I know, I was going to say I didn't say that. I apologize. I'll change the question for next time. Anyway, I apologize. Yeah, I do apologize, actually. This is a really nice diagram. This is taken from a question bank, this question. I trying to adapt it. It didn't go very well. It's actually quite a nice question bank, would recommend it. So when we evaluate primary amenorrhea, the uterus present or uterus absent changes how we investigate and work up the patient. The serum, if it's present, then you always order a serum FSH, regardless of secondary characteristics or not. If it's increased karyotyping, decreased cranial MRI. If the uterus is absent, you know something is wrong. So karyotyping instantly plus serum testosterone, and you compare the karyotype with testosterone levels. If they're female testosterone levels and XX, which is abnormal Mullerian duct development or tract development. If it's male level testosterone with XY karyotyping, then you know it's AIS or androgen insensitivity syndrome. Okay, this is a question. These kind of conditions were tested last year for us as well, you know, exams and what's it called again? VIA. Okay. Yeah. Wonderful. Next question. Sorry. The next question. No. Sorry. Next 2 questions are about miscarriages, abortions. I kind of changed the terms around. I do apologize. So 22-year-old G1P0 at 13 weeks is brought to the ED because of vaginal discharge and low abdominal discomfort. No passage of tissue from her, wow, misspelling, from her vagina. Denies tobacco, alcohol, or drugs. She has no history of trauma. On examination, temperature 37, 76 beats per minute. Rest rate 14. A speculum examination shows a closed os, slightly tender uterus, and normal fundal height, free at neck sag, and scant irregular bleeding from the introitus. The ultrasound shows a normal fetal heart. What is the most likely diagnosis here? Incomplete miscarriage, threatened miscarriage, complete miscarriage, and so on and so forth. Alrighty, so the answer here is a threatened abortion, so good work. So same answer options. A 24-year-old woman presenting for antenatal checkup at 12 weeks. She's been feeling well for the last 4 weeks because she's no longer vomiting or nauseous. Physical exam shows a closed os, nil fetal heart tracing heard. Ultrasound shows collapsed gestational sac with absent fetal heart motion. Urine pregnancy test is still positive, however. What's the most likely diagnosis? Incomplete abortion, threatened abortion, complete abortion, inevitable abortion, missed, topic, identical mole. Okay. I was wondering why you're looking at me, Chelsea. I'm like, what's wrong? Okay, there you go. Okay, so suddenly her pregnancy-associated vomiting has stopped. It's a closed os, no fetal heart tracing heard. There's a collapsed gestational sac and absent fetal heart motion. So the answer would be good. It's a missed abortion. A spontaneous miscarriage or spontaneous abortion is defined as loss of intrauterine pregnancy before 20 weeks. Recurrent miscarriage, which is a subtype of 3 or more consecutive pregnancy losses, you must investigate them with a thrombophilia and vasculitic screen. It's a very nice table of the different types of miscarriage. Okay, the definitions change between UK and US and Australian textbooks. There are no guidelines on the definitions. We went through just what's known as a missed miscarriage as well as a threatened miscarriage. Any bleeding in the first 2 trimesters is technically a threatened miscarriage. Okay, this is a missed miscarriage because there's no current bleeding. It's closed os. No, the fetus is not live, and there's no products of conception passed, so we don't know if they've passed. Okay. In terms of management, depends on the type of miscarriage. You have expectant medical and surgical management. Most important thing in terms of your clinical skills is to always offer grief counseling and support. That's something that we often forget to do. The management will also change depending on the support they have, how far away they live from hospital as well. Okay, these are the guidelines taken from the prompt guidelines, and that's what you'll be tested on in terms of your exams. Question 23. 28-year-old prima gravid woman presents for follow-up antenatal care. Pregnancy normal to date. She's now at 40 weeks gestation. So she's normal fundal height. Cervix is not favorable. Fetal heart tracing is reassuring. She wishes to continue with the pregnancy rather than inducing her labor. What should she be monitored for? What's the most risky thing that you're worried about? Polyhydramnios, oligohydramnios, placental abruption, placenta previa, and preeclampsia. Alrighty, so either you know this or you don't, so there's not too much thinking here. The answer is oligohydramnios. So just a few more questions, everyone, and then you can go. So this is a post-term delivery or post-term pregnancy. Anything greater than 42 weeks, we start monitoring after 40 weeks. The answer is oligohydramnios. Management is you can either induce labor or you can do close monitoring. So at 40 weeks to 41 weeks, you can sweep the membranes and see if anything happens. Then 42 weeks and onwards, you do twice weekly fetal surveillance. So an amniotic fluid index and CTG twice weekly. And you'd also, every time you do that, you'd also examine, do a speculum examination and assess for cervical favorability in terms of a Bishop score. The reason why you do twice weekly and the reason why this question exists is because for post-term pregnancy or post-term delivery, these babies that are very high risk of oligohydramnios, and the amniotic fluid index, or the amount of amniotic fluid, can change within 24 to 48 hours. Okay, so twice weekly or thrice weekly is making sure that you can check that there's enough amniotic fluid before it becomes a problem. Okay, there's again very nice guidelines about this on prompt. Question 24. So these questions progressively become a bit easier. The 25-year-old woman, G2P1, 32 weeks, brought to the ED, pregnancy uncomplicated, but she has a history of cocaine addiction. Ooh, buzzwords, wow. Ultrasonogram performed at 16 weeks shows no abnormalities and growth is to dates. I was about to say something else, but I forgot what I wanted to say. An examination, temperature is 37, BP is 130 on 80, pulse is 90, breast rate is 15. There's tenderness present, hyperactivity, and increased uterine tone. Maybe there's even a woody uterus. Ooh. Oh, wow. Fetal heart tracing shows 140 minutes with decent variability, both baseline as well as concurrent. So which of the following is the most likely diagnosis? Is it normal labor, uterine rupture, vasa previa, placenta previa, or placental abruption? Oh, wow, okay. Good. So placental abruption, so painful third trimester bleeding, always think placental abruption, okay? If there's no trauma, okay, and there's no previous C-section, always think placental abruption. If there is trauma, previous C-section, previous surgery, think uterine rupture. The separation of placenta from the decidua prior to delivery of the fetus, and that's how it looks, okay? The risks are as follows here, and in terms of presentation, more importantly, you often can get PV bleeding, but sometimes you don't. It can be a concealed, I think, placental abruption, continuous abdominal pain, tenderness and palpation. You get a woody uterus. You get a woody uterus because of increased uterine tone. Why do you get uterine tone? Because the uterus kind of tamponades itself. The uterus tamponades itself, increases its own tone, becomes a woody uterus. So it sounds and feels like wood. That's a uterine response to bleeding. These patients can be in shock depending on the amount of PV bleeding. In terms of abruption, ultrasounds, they're okay, but it's more mainly a clinical diagnosis. Always do a Kleihauer because you have to give these patients if they're rhesus negative, rhesus D. In terms of management, there's both expectant as well as surgical management. Depends on the stability of the mum as well as the child. Really important note is you never give tocolytics. If you were to give tocolytics, what you do is you actually down titrate or you kind of depress this uterine tamponade effect. And you don't want to do that because that actually stops some of the bleeding. Okay. Again, you can read through those notes at your own convenience. Next question. 25. So a 20-year-old woman, G0P, G0P0 presents to the ED with complaints of vaginal bleeding and right lower quadrant pain. She's sexually active, uses condoms when she wants to. Temperature is 37.2, BP is 120 on 74, pulse is 80 beats per minute, rest rate 14. Exam shows right lower quadrant tenderness, but nil guarding, there's no rebound tenderness. There's no active vaginal bleeding, and the Oz is closed. HB is 110, rhesus positive, beta HCG is 1,000. On transvaginal ultrasound, there's no pregnancy seen. What's the next best step in management? Consent for immediate laparoscopy. methotrexate administration. Repeat beta-HCG in 48 weeks or 48 hours. Administration of anti-D, 48 weeks. Yeah. Consent for dilation and consent for dilation and curettage. All right. So we have only 2 more questions or 3 more questions. So if you're planning to go at 3, just bear with me, just a few more minutes. Alrighty. So repeat beta-HCG, so good. So important learning points from that. In terms of the levels of beta-HCG, you may or may not see pregnancies. We expect a beta-HCG of 1500 to 2000 to be seen on transvaginal ultrasound. And you need up to 4000 to be seen on transabdominal ultrasound. Okay, so you'd repeat the beta-HCG in 48 hours to confirm if there is indeed an intrauterine or extrauterine pregnancy. Alrighty, question 26. 28-year-old female G1P0 presents to her booking appointment, brimming with excitement. Whilst doing the standard battery of tests, her random blood glucose returns as 8.5. All other tests and examinations are normal. What is the appropriate management for this patient? Start insulin, start metformin. OGTT now, OGTT at 28 weeks, HbA1c, referral to specialist diabetics, a specialist diabetes service. Do I have to? Yeah, sorry. Alrighty. Okay. So let's go through this now, just quickly. Gestational diabetes is a study in and of itself. This is a really nice diagram that I can't claim any credit for, made by my housemate last year, Judge Anderson. So you'll get a copy of this, really nice. So it goes through the different steps of management. So at your booking visit, the question, what it tests, at your booking visit, you always do an RBG, and depending on the results, you'd organize your OGTT. If it's less than 5, fine, organize it for 28 weeks. If it's more than 11, means that they're diabetic and they need specialist diabetes service. If it's in between 5 and 11, or 7 and 11, depends, then you have an early OGTT, which is around 12 weeks, or however, booking visits around 12 to 14 weeks, so you do an early OGTT. As you may know, there's other indications for an early OGTT, like previous GDM, sister with GDM, certain ethnic backgrounds, and so on and so forth. Okay? You just quickly go through this. So you diagnose it with an OGTT generally at 28 weeks, but it can do earlier for those at risk at 14. Always talk about MDT team when it comes to your OSCEs. In terms of management, first it's diet control, lifestyle intervention, and then metformin or insulin. Depends on the service, depends on where you are. There's different preferences. In terms of birth, is, you may consider a C-section if they're macrosomic, but always aim for delivery 39 to 40 weeks. Okay, if they're getting to 40 weeks and they're not nearing labor, you induce labor in these patients. Okay, there's increased fetal monitoring requirements after 36 weeks. Follow-up, also really important, often missed when it comes to counseling, but you often have to see these patients and do a follow-up OGTT 4 to 6 weeks after delivery to make sure that the diagnosis is GDM, not actually frank diabetes. Okay, so if it's still raised now, then they have normal diabetes and they have to be managed in that regard. Okay, this is the final question. So before the final question, thank you. I think some of you might remember that in first year, myself and Mendel ran the first MUMUS lecture you guys went to, so on biochemistry. And it's been a pleasure and privilege to be able to help you in whatever small way that we have. Until then, look after yourselves the next 6-7 weeks. Look after each other. It's a tough time, and I'm sure that all the fifth years, not just me, but we'll be willing to help anyone who needs an extra hand. Okay, so we'll finish on this question because this is about you. Kylie, a 23-year-old woman, is on the Minipool for menses control. She's a past history of migraines. This morning, she's in a migraine attack with 2 episodes of vomiting on either side of her taking the Minipool. She calls you, a sibling in medical school, for some advice. What would you say, my future doctors? Okay, advise Kylie she's fine and that she's protected. She's protected. You got her back. Advise Kylie that this counts as a missed dose and she must be on double contraception for 7 days. Advise Kylie that this counts as a missed dose and she must be on double contraception for 2 days. Advise Kylie to start the combined oral contraceptive pill as it has a greater window of compliance. Yeah, I know. Alrighty. Final few answers popping in. So I'm really waiting for some questions or OSCEs on the progesterone-only pill. I don't think it's really tested enough, but perhaps. Anyway, answer is 2 days. All right, wonderful. Good luck. Thank you, that's okay.
Hey everyone. Hey everyone. Thanks for coming today. I hope you all found it really useful. Thanks to all the speakers as well. If you could just take one of those boxes of like empty rubbish, that would be really, really helpful. And just put it like in a bin somewhere in the uni because they don't all fit like in this bin. But thanks.
For like a week.
Yeah, no, that's okay.
But how you doing?
Yeah. I mean, like, I'm on ED now.
Share with and meeting. And meeting.
And that is just a fact. Lighthearted. Thanks, Blair.